Good morning. I'm one of those on-time people. I don't like to get started late. My name is Cindy Yan. This is like, it's on. So y'all don't hear the little feedback that I'm hearing. Okay, that's good, as long as you hear good stuff. I am the current president for the South Texas APS Community Board, and I'm going to do a quick hello and welcome to our 5th annual symposium. Mostly right now, though, I want to introduce our first speaker, one of my favorite people ever, Ann Cortez. She is the director for the South District of Adult Protective Services. And I just learned, I knew it was a lot of counties, 47 counties. That's a lot of area, girl. Thank you, and let's welcome Ann to give us our welcome this morning.
Thank you, Cynthia, and good morning. Now I get it. I get your feedback. Thank you and good morning to everyone. Cynthia mentioned that it was the 5th annual, and we were visiting this morning trying to figure out, was it the 5th or is it 10th? But I think for this particular event, it is our 5th annual. We've had partnerships with many people throughout this city and county and area, and have had symposiums of this type for many, many years. And Adult Protective Services is proud to work with these partnerships so that we can continue providing information, educational information with regard to aging issues, elder abuse issues, and services for people in our community. I was told that we have over 130 registrants and over 70 folks online. And every time I come, this grows. And so they were talking earlier about looking for, we may have outgrown our venue, but this has always been a great venue for us and a great partnership with ACOG. You'll notice in your agenda that I'll be back for a panel discussion, and I think that this information is valuable when we're looking at ethics and concerns for persons that are aging in place, and what are some of the ethical issues and dilemmas that not only caregivers face, but all of us professionals face as well when we're attempting to help the most vulnerable in our community. So I really, I'm thrilled with this agenda, and I really hope that you all are thrilled with it as well. So welcome, and we will go ahead and get started.
That's it. Gotcha. All right. My job wouldn't be done if I didn't do a few thank yous this morning, because you're here. It's cool in this building. It's nice. We're not out in the heat, and we're having yummy food. And so none of this happens without some really hard work. So I want to first kind of call out the members of the Education Committee part of the board, and they're probably running around, but if you're here, stand up or wave your hand. These folks have put in hours of work to make this possible for us, and we thank them so very much. I want to thank ACOG, obviously, and Ann did as well, for this great venue, and we appreciate being here year after year. Senior Planet from AARP is handling all of our technology today. They make it possible for this to be a hybrid seminar. So if you didn't want to be here in person, you could be sitting at home in your jammies, watching virtually, but they've made that possible, and we thank them for that. Sage Care Management has made it possible for those of us that want CEUs, and Byron Cordes with Sage Management is going to be here in a little bit. He'll do some housekeeping and kind of tell us more about that if you need more information on that. And of course, obviously, a thank you very much to the Texas Department of Family and Protective Services, APS. So we thank all of those folks. And then absolutely, last but maybe certainly not least, On our big screens and your screens, they're going to be flashing some slides that have a list of all of our sponsors and exhibitors today. These folks gave generously so that we could be here today and enjoy what we're going to have. So we thank them so very much. I'm not going to call them all out because you're going to see their names up on the board, and we couldn't be here without them. So just very quickly, a little bit of a round of applause, if we could, to thank our committee and everybody that's helped. All right, please don't forget to, and I know Byron will tell you this, don't forget to visit the exhibitors booths, which are down the hall, as well as up here at our front table during your breaks and during the lunch hour. They've got lots of goodies you can take with them and lots of wonderful information you don't want to miss out on. I'm going to take just a moment to step over here. The next item on our agenda is one of things that's very near and dear to my heart. Oh, okay. We're going to take a quick little break. Talk amongst yourselves. We're checking for attendees that we need before we can go forward. You can't give out an award without the awardee being here. So we're going to set that off for a little bit later. So with that said, though, we're going to get right into our good stuff. And it's see, I know I brought it up here. Our Master of Ceremonies, which I will introduce to you later, is stuck in a meeting he cannot get out of, and he normally does our introductions. But I talked to our wonderful Dr. Patel, who many of you probably know. She is our first speaker. She is with UT Health Science Center. She can tell you everything more about herself, but she said make it short and sweet. We love to have her with us, so please join me in welcoming Dr. Patel.
Well, I said, I'm another human soul like everybody else here and sharing the same common mission and goals. We all are helping older adults in some form or the other. And that's the only relationship that we have. And that's the only introduction about me that I think is important. So last year, I think I spoke about loneliness, and this year I'm talking about age-friendly health systems, what matters most. Is somebody going to move my slides forward? Okay. So the UT Health Science Center is, all of you are seeing that there is a new building coming up next to our main practice. That's going to be the Center for Brain Health. And they are a little different center in terms of they have primary care, supportive care, and comprehensive care integrated within the center. And there's a lot of community that's going to be engaged into the center. We have a community garden that the community, the persons with dementia, their caregivers can come and tend to. We have music therapy there. We have yoga and Pilates and exercise rooms and special rooms for family meetings. We know it is out there in the Health Science Center, and it may not be easy travel for everyone, but we are working to see how we can make transportation possible. And this is the beginning. The center is in the Health Science Center, but the vision is to have a similar center in collaboration with the other senior centers in San Antonio to make what is available in the center for the community. So I'm not sure how many of you are familiar with the 4 M's of age-friendly health systems. A show of hands for the audience that's here, and the people online, if you can just, I think, yeah. So can we go back one slide, please? The 4 M's are basically by the Institute of Health Improvement, a framework. We all know that aging is not a disease and aging is life. Aging and ageism is not related to a number. It's not when you turn a certain age that you start aging. We all start aging from the time we are conceived. Okay. Each and every day, we get a day older. And as we get older, there are changes in our body from head to toe. But they are not just changes physically, there are also changes mentally, emotionally, socially, and spiritually. When we are younger, health is mainly physical. If we are able to be functionally independent, physically independent, we feel we are healthy and we take health for granted. As we get older, health, our physical health, depends on how we feel mentally and emotionally, what is our social health situation, and loneliness was a big part of social health. What is our spiritual health? It's not about religion, it's about who we are, why are we here, what is our purpose. When we are younger, it's very easy for us to have a goal and think of education, wanting a family, wanting work, wanting to contribute to community. But once we are older and retired from work, what is our purpose? And that, trying to find meaning in life, trying to find a sense of purpose, trying to be at peace with what one has, how one has lived, is the spiritual health piece. That also, to a large extent, determines our physical health. Okay? Because depression can go a long way when you're not feeling socially supported, when you're having a very low esteem or thinking there were way many things you could have done in life differently, but we can't go back and undo it or delete and start all over again. And so it's a quest, and that in turn influences our physical health. What I will be focusing on today, so aging is life. As we get older, what's most important is mobility, ability to be functionally independent for personal care, is mentation or mind, not being depressed, not having any memory issues, and being able to meaningfully communicate and connect with the community. Medications, as we get older, we have every organ of our body has some problem. And so each doctor only sees the organ and not the person. I see you smiling here, and that's true. And the challenge we have in our team is telling our patients getting older is life, is not a disease. You don't need a pill for every illness. You don't need a doctor for every organ. You need to just be seen as a whole person, and how you need to adapt to your life, change how you eat, how you need to be active within your functional ability, and contribute to yourself and to the community in whatever way you can. There's no one size fits all. But the most important thing is what matters most to the person, the preferences for life. Okay. And meals, as most of us working in making sure our older adults are safe, meals is one big thing which is a challenge. And as we get older, we all realize food is one of the most important thing. We enjoy food the most. There are many things that we let go, or many things that we aren't able to do the same way as we could do when we were younger. But there's one thing that still remains, is enjoying food. Okay. So the main things I want to discuss today is just briefly talk about the 4M's framework, but then focus more on what matters most. And that is really advanced care planning for life. Explain where to start, how to start, identify how to make shared decisions, and demonstrate the impact of advanced care planning, or what is most important. Many times we see older adults in the hospital and they end up telling you this is not what they wanted, this is not where they wanted to be, and still they're there. I have a 91-year-old patient right now that I am taking care of, who is dying. And a daughter, a physician, a leader is not able to accept her mom's dying. And she still wants a lot of things done. But is that really what her mom wants? Is that what her mom wanted? That is why it's important to have these conversations. And this is not just the responsibility of the older adults physician team. This is the responsibility of family. This is the responsibility of anybody who is involved in supporting the life of how well the person lives. Next slide, please. So the age-friendly systems is what matters most: mentation, mobility, and medications, which I mentioned. Also, meals is the most important thing. So we make it as the 5Ms instead of the 4Ms. And the American Geriatric Society, their 5Ms framework has multi-morbidity because it is a geriatric society and medically focused, but we are more life focused. And so you really want to focus on the meals. Next slide, please. So meals, we want to ensure, if you look in this pyramid here, you really want to ensure the bottom of the pyramid is hydration. Okay. As we get older, we tend to forget to hydrate. We do not want to hydrate because you don't want to go to the bathroom so often, you know. And so I keep telling my patients, the more fluids you drink. So I'm very happy to see almost everybody here has water or some kind of drink in front of them. It's important to hydrate, and it's okay to go to the bathroom more number of times. That gets you to walk, so you're being more mobile. And that is something that's not included in most of the food pyramids, but in older adults, you want to make sure that that is definitely included. Our body is 90% water, and as we get older, one of the changes is losing muscle and subcutaneous fat. And so the skin is very, very thin and loses water very easily. And that's an insensible loss of water. So we don't realize that we're losing water and that we're thirsty. And we don't feel thirst. When we get older, you don't feel thirst. But you may feel hungry, and you're not necessarily hungry, you're actually thirsty. So I tell older adults that when you feel hungry and you've just had breakfast or lunch and you're wondering why you're hungry, just think you actually may be thirsty and you want the water. To focus more on a lot of fruits and vegetables. And I know dentition is an issue, and sometimes chewing and salads can be a little difficult, but maybe like having it in the form of a smoothie, or just churning it and having it, or cooking it in a soup, the vegetables especially, so they are softer. The other is having good protein in terms of white meat, eggs, milk, yogurt, beans, lentils, legumes, all of that. And then having carbohydrates in terms of breads and tortillas or rice to be like the very little amount. And of course, we do need oils and fats. Some of it we do get in milk, yogurt, cheese, and all that, but and avocados. But some of it you do need in your diet, whether it's olive oil or any oil and butter. It's not all bad. It's just how much you have is what you've got to be mindful of. Next slide, please. So, what matters most is to know and align the care with each older adult's specific outcome and goals of care. Each one's preferences are different, and there's no right or wrong. We have patients who will say that whatever happens, no matter what, they want everything to be tried and done so that they can live well. You know, even if it is an invasive procedure where there is a risk of death, they really want it because they want to give themselves a chance. They don't want to lose that opportunity of it may be better for them. If an 89-year-old with severe heart disease, catheterization showed they could not put a stent for him. He's highly functional, and the cardiothoracic surgeon suggested if you want to live, you do need to take a risk of having a bypass surgery. And family was very concerned, but he said, I don't want, if I don't do anything about it, the next time I get a heart attack, I'm going to die. If I do something about it, I at least have a 50% chance of I may be having a better life. And if I don't, I'm okay with the transition, but I still want to try the surgery. So each one's preference are different. And we all deal with older adults who may be having cognitive impairment. But just because they have cognitive impairment, it does not mean they do not have decision-making capacity. Unless it is advanced and moderate cognitive impairment, they are able to express their needs. If, in their own simple terms, a person is able to tell us um, what the procedure is and what are the risks for it, and they still want to go with it, you take their word for it. And that's why the next half, we're really going to focus on advanced directives and how it's important to get this information much before cognitive impairment. And even if they're diagnosed with cognitive impairment, how to support the family so that we can get the preferences of the person and not the preferences of the children in this. Then the advanced care planning, most of them think it is talking about dying and don't want to discuss it and do it. But it's really no, it's you're planning your life for life. We plan everything in our lives. We plan birth, you have baby showers, you have birthdays, you have, quinceañeras or sweet 16s, and you have engagements and weddings and everything. But we don't want to celebrate life. The biggest celebration is letting everyone know what your preferences for life are. As long as we're breathing and our heart is beating, we have life and we need to live it. So it's not about how one wants to die, it's about how one wants to live as long as they have life. Medications, really, the lesser number of medications is better. And as I mentioned, every illness doesn't need a pill. And sometimes the pill is the reason, actually, most of the time, it's the pill that's causing the problem. Pill that's causing the dizziness, pill that is causing the diarrhea, pill that's causing the drowsiness, sleepiness, falls. Okay, so you really want to educate our clients on medications, the lesser, the better. Sometimes the pills also affect the mobility because they feel very dizzy and all that. They're afraid of walking, that they may fall. And it can also affect the mind, confusion, and um, sleepiness, depression, drowsiness, memory issues too. So many of them take over-the-counter Benadryl. It's called as Unisom or something. That's the worst medication a person can take who's getting older for sleep. It's not safe. And just because medications are available over the counter, it doesn't mean they are safe medications. Okay. It's just FDA approves that it's not going to kill you, but it's not going to help you live better either. Okay. Next slide, please. So 1 in 5 older adults takes more than 10 medications. When the more medications they have, there's more risk of them not taking what they really need every day. There's medication errors, there's interactions between the medications. Everything shrinks as we get older. We lose height, we lose muscle. So the gut also shrinks, and the absorption of food and medications is very less. So if you're giving 10 medications, but they truly need only 3 for the blood pressure or or diabetes or something, but they're taking 7 others as supplements, or just because a neighbor told them, or they saw something on TV and marketed. I don't know how many of my older adults were taking Prevision, and that was not cheap. It was very expensive, and with a limited income, why would you spend on something? If it was really benefiting memory, you wouldn't be getting it that easily. Okay. The prescribing cascade. So every organ has a doctor. The heart doctor doesn't talk to the lung doctor, doesn't talk to the kidney doctor, and they keep on prescribing, and some of them prescribe the same medication. Drugs interacting with one another, and drug disease interactions. Like, for example, some of the medications we choose for the heart and to treat blood pressure actually brings your blood sugar down, like the beta blockers, like the metoprolol and the carvedilol. So patients don't know that, and they'll continue to take the high doses of insulin or medications for diabetes, not realizing that this new medication that the heart doctor has started is actually going to affect their blood sugar control. Next one, please. This is truly a patient's medication list. And this is only the prescribed medication photograph that I took. She came with walk-in, the baggage that we take for travel, that she had a full one. She had a full one. A lot of it was supplements from GNC and everything like that, but these were the prescribed meds. And those 5 bottles that you see were 5 different doses of a blood pressure medication. She wasn't taking the lowest dose itself because she wasn't feeling good, but she was afraid to tell her physician that she doesn't feel good with it. So every time she went, her blood pressure was high. Every time they kept on increasing the dose. And then her blood pressure was dropping up and down, because one day she would take the 5 milligram dose, another day she would take the 10 milligram dose. And so there was no consistency at all. And all the number of bottles with the automatic refills, while the automatic refills is a good thing, sometimes it really does not coordinate and link with any changes in the doses, or if you've stopped a medication, there's really no good way of making sure that the medication list is current and accurate. So this results in falls, hospitalizations, fractures, or even loneliness because they don't feel good. So then they'll stop going to church, or they'll stop going to the senior center, or they stop going to meet their friends for lunch or dinner. And many times for cognitive impairment, the medication side effect is diarrhea. And so they don't want to go out because they don't want to have a bowel movement in a public toilet. So medications, people think a medication is actually going to help, but it's the other way around. It actually does more harm than really good. There are only 2 medications that are really safe for older adults. Any guesses what you think they are? And both are not prescription. They're available over the counter. What did you say? So Tylenol, yes, it's a safe medication, even if they have liver conditions, Tylenol. And what is Gerantal? No, you don't need vitamins, honestly. Fiber, or for any medication, a stool softener. Okay, that anything that helps with constipation. Everything else you want to ask whether they really need the medication. So one of the things we can do is educate our older adult clients that every time they go to the doctor to question, do they really need so many pills, and do they need the same dose? Because as we get older, we don't need as many medications or as much medication as we were taking. The doses get lesser and lesser. Okay, next slide, please. So basically, we want to have a simple regimen, try to simplify and make it just once a day because they may forget to take it second time, and they don't wake up as early. Some do, some don't. So each person is different, but based on whether they are early risers or late risers, trying to simplify, looking at options that are not medicines for treatments. Like for arthritis, they really don't need strong medications or don't need the hydrocodone or, the opioids. Exercise really helps. They'll say it hurts. It hurts initially, but when they consistently do it, it really helps. Foods, recommending the right kinds of foods to eat. Now, foods, it's not enough to just print out pyramid and tell them this is what you need to eat. It has to be personalized. What is it that they have for breakfast? What they have for lunch? What they have for dinner? What do they snack? And then recommend what they can have less of and what they should try to increase to help manage their conditions without having to take extra pills. Heat, ice, all non pharmacological interventions help as we get older because it's life. There are changes in body. A pill is not going to fix it. Making adjustments to how we live is going to make life better. Every time they go asking to deprescribe and to see what medication they can stop. And for the medications that they have to take, family members can help with reminders. And these days with video, phone, making sure that they really are swallowing that pill. The pill boxes, they really haven't been very successful. Even the one with the alarms and all that, sometimes it confuses them and they get distracted so easily. Managing medical problems, making sure that they have the regular checkups and really simplifying the number of doctors. This is the hardest thing to do because they've had these doctors for 30, 40 years and they find it really very hard. And the doctors will keep on automatically doing blood draws and all that, which is not really required. You, you're you don't want to order a test just because you have to order it. What are you going to do different after you order the test? And just to look at a number, you really don't need it. Numbers matter when we are younger. Numbers don't matter when we are older. You don't treat the number, you treat the person. I have patients who, if I try to bring their blood pressure down to 130 or 140 by 80 or 90, they don't do well. They get up and they feel very dizzy and they stay isolated in the house. They're much better with their blood pressure more closer to 150 by 80 or 150 by 90. So each person is different. And some patients have blood pressures in the 90s by 60s or 100s by 60s. But if they're fine with it, we don't need to give a medication to raise their blood pressure. So it really has to be simplify, simplify, simplify is a key over here, and less is better. Okay, next slide, please. So mentation, you want to prevent, identify, treat, and manage not only dementia, but depression and delirium, which is an acute confusion. And acute confusion of delirium need not necessarily be only in the hospital. They could have started a new medication. There could be a change in environment because children are visiting. We do home visits. Yesterday, I went into a home, 4 grandkids, and the person having cognitive impairment. It was really frustrating him because it has totally upset his routine. And his wife was saying like he was getting up in the middle of the night and walked into the pantry to go urinate. And this was the first time he did it. He was really very, very confused with this change in routine and with grandkids. So it's not that they shouldn't be with grandkids. You need to prepare them. You need to let them know that this is going to happen. And their daily routine, you need to make sure that we are not changing it to a drastic extent. Like the time they wake up, they go to bed, the times they have their meals, their activities that they do should continue irrespective of who else is visiting the family or not. Most important here, especially for us, is depression. Because if depression is not identified, depression is not treated, it does lead to the brain changes occurring for dementia. So it's very important to screen for depression with just two questions. In the last 2 weeks, do you feel like you've lost motivation in doing things? And do you feel down, depressed, or sad? Okay. Mobility, we don't have to talk about exercise, but get a sense of how much they walking. And then the PPS channel has the sit and be fit and the stretching exercises from 1 to 2, 1 to 1:30 and 1:30 to 2. And we undermine the value of stretching and flexing, but that's really important for balance. Next slide, please. So mentation, you want to screen for depression, every interaction we have with them. Cognitive screening, you can at least do, I think, the mini cog. And I'm not sure in your day-to-day work, do you all screen for cognitive screening for their memory? Yes, no, no screening. So y'all don't do any cognitive screening working in uh, adult protective services as care managers or something. Do you all do it or not? No. Okay. You refer it out. Okay. So how do you identify that somebody has cognitive impairment? I think if you can use the mic so people online can hear you as well. Thank you.
So from a adult protective services standpoint, we'll look at history if we have history and recidivistic cases. If it's a brand new case, we'll attempt to talk to collaterals to try to get a base.
Mm.
So part of the investigation, at least for the first part of it, is to determine a base. Um, if there are questions with respect to cognition, we refer that out. We'll look for a primary, if they have a primary care physician. If they don't, we have services available that we can refer them out so that we can get a professional um, um, assessment of the client's cognition. Um, we encourage and expect our staff to make visits at different times of the day so that we can also use that information to form a base. And it really depends on the allegation. If we're dealing with a self-neglect allegation or perpetrator-driven allegation. And so it really takes a level of understanding, with adult protective services and the training that we provide staff to identify a base of where this client was.
Okay. Thank you. Thank you for sharing that. So maybe then just asking for whether they are depressed or sad or they have any memory loss. Functional assessment, you really want to ask about their abilities to do personal care, dressing themselves, bathing themselves, feeding themselves, their ability to go to the bathroom, whether they're wearing pull-ups depends or they still have control. And then the domestic care, who is helping with buying their groceries, doing their cooking, their cleaning, their laundry, paying their bills, managing their medications, their ability to talk on the phone, you know. Mobility, we do just, it's a very simple test, is just to look at how stable they are. Whichever room they're sitting, just having them getting up and walking at least 8 feet or 10 feet. Um, Other is, and it should be done within 10 seconds, or we give a limit of 30 seconds because we see patients older than 85. And whether they're able to get up from a chair without holding the side arms tells a little bit about their ability to have a good balance and gait and their risk for fall. Whether they use a cane, walker, wheelchair, we do want to screen for whether they fell, because they think falling is a normal part of aging, and it is not. A fall is a preventable event. And so we do have to screen for falls to understand the mobility. And vision and hearing affects mobility too. So if they wear glasses, do they wear glasses? When was the last time they saw their eye doctor? If they have hearing issues, if they have hearing aids, and if they um, are working, because many of them do have hearing aids but they don't use them because it doesn't help, or it's really the battery keeps getting out and they have to keep changing the battery and it really doesn't work the way it should. The next slide, please. So now coming to really what is most important for them is advanced care planning, planning life in advance for any healthcare decisions specifically, making your wishes and preferences known for healthcare and letting others know about it. All the family, but also their doctors and everybody do need to know what their preferences for life and for their healthcare are. Next slide, please. So healthcare decisions making plans, legal planning as well, in the event that they are not able to make any decisions on their own. Either they are unconscious, they have cognitive impairment and do not have the capacity to make their own decisions. Then who is going to be their speaker, their representative, not their decision maker? Because their decisions should have already been made if they have the advance directives done. Okay. Just a person who will be their spokesperson and represent their preferences and their values. So you do need like the entire advanced care packet done, and it can be open to where they could print out and write paragraphs. I have patients who have handwritten advanced directives where they write out, if this happens, this is what I want, I don't want, and all that. So it's not restrictive. And you also want to name two people. One is the primary, and if that person is not available, who is the next person to ask? Financial planning is an important part of advanced care planning. If you have loss of function and abilities, then you do need to look at what your finances are for whether you want to live in an independent living community or assisted living, or if you're going to need nursing home care, because none of this is covered by any insurance. Even long-term care insurance doesn't cover it 100%. So you do have to plan, and especially if a person has a diagnosis of dementia, they're going to need caregivers for support for personal care, for basic necessities of life. So it's important to do the financial planning. And those who don't have the financial resources, or the resources are there currently but are not going to last for the entire lifetime, planning for Medicaid earlier in advance rather than later. And care plans for life, you know, um, don't make it about diagnosis. Don't make it about dementia or heart failure or diabetes or COPD or pulmonary fibrosis. Make it about life. How does this diagnosis affect your daily living and what is important to you? And how would you like to live despite all these challenges? Next slide, please. So, as I mentioned, you do need a medical power of attorney. You do need preferences and wishes. And you need, and even if in your preferences and wishes as advanced directives to physicians, you say that in the event of natural death, you do not want to be resuscitated, you want to honor the universe call of transition, you still do need to have an out of hospital do not resuscitate, because the advanced directives is to physicians and would work in physicians offices and any healthcare settings. But if something were to happen at home, which is most of the time, you really do need an out of hospital do not resuscitate, because EMS, first responders, are not physicians and they need a separate order. And the out of hospital DNR is their order. Okay. One and two is how you want to live, you know, when you are breathing and heart is beating. The out of hospital do not resuscitate or the DNR, even if it's in the hospital, is when natural death has already occurred. Most of the time, our patients say, I want to try. What if I come back again? And I say, no, nobody ever comes back after dying. Okay. So the out of hospital, and that is a guarantee. I think there's no guarantees in life. The only guarantee we have that we are all going to die someday. When it is going to happen, nobody knows. But when it happens, it happens. And no amount of whatever you do, you're going to come back. Okay, so that is the decision. After you're dead, do you want to be left in peace and transition, or you want to be hooked to a machine? And then it becomes even more difficult because they're already dead and they're living on artificial life support. They're not even living, they are on artificial life support. And then it becomes more difficult for the families and the people left behind to make that decision of taking them off all the external support. So clarifying what DNR is and that it is just allowing for natural death. Next slide, please. So medical power of attorney not necessarily has to be children, unless it's someone you trust and who will represent you and your preferences. I have many children who are the medical power of attorney and they'll say, well, I am the MPOA, so this is the decision what I'm going to make. So we are, this has been an APS case. I'm not taking any names, so nobody's ever going to know who I'm talking about. But there's this person who has dementia, lives with his wife. His daughter, who is a retired physician, is the medical power of attorney, doesn't live here in San Antonio, lives in Denver, does all the care remotely, and doesn't even call on a daily basis or anything. And the wife is the main caregiver with support from paid caregivers and will be telling us when we go for our visits what the husband concerns are. And when we give treatments, but then the daughter from Denver will keep on, intervening and saying, no, she wants this and she wants that and she wants that. So that was the reason why I brought an APS. You have a legal medical power of attorney who's not representing the best interest of the person. And then you have a wife who's doing what's best for her husband, and the daughter is not allowing it. And I had to clarify and tell her, listen, your dad's preferences are already written down. You cannot be changing what his preferences are. You've just got to honor that we are following his preferences. In fact, if we are not following his preferences, you should be advocating for him and telling us to do it. Here it's the other way around. I'm asking you to shut up and stay out of our way. you know? So it is truly, I had to be that blunt with her because being nice with her was getting us nowhere, you know? So, and then, so it's not necessarily that family is the best. And then I have patients who will not appoint children, and either nieces and nephews or friend or neighbor or somebody else, because children haven't visited them. It's one FaceTime or one phone call. Don't come for birthdays, don't come for Mother's Day or Father's Day or any holidays. Always are busy and working, then it's the neighbor or somebody else who they trust, you know. And when who will be the spokesperson when they're not able to speak for themselves? The next slide, please. So the types of decisions that might need to be made are the preferences and wishes of the person. And my next slide has all the details of what are the preferences we want to talk about. And considering those decisions ahead of time and letting everybody that's important to them know about the decisions, especially family and the healthcare team. It's all about what matters most to the individual. What are their preferences, their values and wishes, and how they want to live. Next slide, please. So the shared decisions, the preferences, values, and wishes are: one is for resuscitation of an allowing natural death. And there is no harm if even after we've discussed and a person says that they would like to be resuscitated, and if to be given a chance, there is no. But then we need to go deeper into the conversation. Okay, we tried to resuscitate you, then how long do you want to be hooked to a machine? Because you can't be hooked onto it forever. Okay, so, and generally in the hospitals, they will not extend beyond 14 days. So that conversation needs to happen. And then feeding, if they're not able to eat and drink or they have swallowing issues, would they want a feeding tube? And this is a very important conversation to have about feeding with the family, that, hey, if I'm not able to eat and drink what I like, I don't want any puree diets, and that's okay. That's perfectly fine. There's the new Choosing Wisely guideline where, because they have swallowing problems, you do not have to give puree diets. Because see, food is the only thing that's really most important. Food is the only thing that is giving them a good quality of life and taste. Why would you take that away from a person? So you want to just adapt with speech therapy. You want to adapt with having them sit upright instead of laying down in bed, or recline a bed up. You want to chin tuck. You can use dysphagia cups. You can alter the consistency of food to help them swallow better, but not necessarily that they have to alter. And feeding tubes, it has shown if they have a condition where they've had radiation or something and the gut is not functioning, a feeding tube may still help. But in case of dementia, where they are not able to eat and drink and they are very advanced, a feeding tube is the worst thing you can do for a person. Okay. And one of the biggest changes as we get older is our need for food, although we enjoy it, is not as much as it was when we were younger. Breakfast is the best meal, and breakfast may not necessarily be at 7:30 or 8 a.m. It may be more like 11 or 12 based on whenever they get up. And then maybe some snack around 3 or 4 p.m. They may snack around in between, like cheese and crackers or fruit or, grapes or something like, or ice cream, or it doesn't matter, but that's fine for them to snack around. So feeding is an important, difficult conversation that needs to be had. Hospitalizations, just because they're sick, it doesn't mean that they have to go to the hospital for everything. There are lots of hospital at home programs, and whatever treatments can be done at home. They don't have to be hospitalized. Okay, so having that conversation, their treatment choices, and supporting them, whatever their choices are. They want to be treated in the hospital, they want to get that radiation, they want that surgery. You've got to, as long as they understand what the benefits and risks of each processes, you honor the wishes, whether they want blood and blood products. So myelodysplastic syndrome, or where the bone marrow does not make enough of blood, is very common as we get older and more common in women than men. And so if your body is not making blood, would you want blood transfusions? Initially, you may need it once in 3 months, and then the frequency keeps on increasing, where you may need it once in 2 months, once a month. And if you need it every week, how long would you want to keep going with blood and blood products? And it's affecting your quality of life. You're getting the blood, but you're not able to do anything else. You're coming back home and sleeping. So how long would you go? Dialysis, you don't have to have dialysis if you don't want it. If somebody is on dialysis and decides to stop, then the life expectancy is like 7 or 10 days. But if somebody who's never been on dialysis and the doctors are recommending dialysis because their kidney function is poor, they can continue to live for a few years without compromise. It's just they won't make enough urine, but that doesn't mean that their kidneys are not functioning. You don't need much of the kidney to function. You just need to do things to prevent your kidneys from being damaged further. Pacemakers is actually a good thing. Many of my patients will say they don't want it, but it actually helps with controlling your heart rate. And many of them have a lower pulse, and that is not good for life. That is guaranteed death. So if everything else is fine, having a pacemaker and setting your heart rate to 60 is actually a good thing. Nowadays, they have the Watchman also, and 90, 95-year-olds can have it. That is for atrial fibrillation and irregular heart rate, which is very common and which can result in strokes, and they need blood thinners. So there's a risk of bleeding in the brain. So it's important to have those discussions. Those are actually helpful, and it's okay to have that. But if you still don't want to have it, that's okay. Then related to donation of organs, whether they want to be organ donors, what are their spiritual preferences, and if they would like to participate in research, especially if they have like diagnoses which haven't been researched enough, if they would like to participate in research, uh, when they are too frail and their life expectancy is very limited, if they would like to participate in research. Next slide, please. So out of hospital, I said already this, only when natural death, and allow for natural death. Next slide, please. Where, when, and how to start these conversations. So I tell my patients that whenever you have a diagnosis, when you have diabetes, ask how the diabetes is going to affect your life and what are the decisions you need to make. What to expect, how diabetes progresses and affects every organ, how hypertension, if you don't control it, it can cause heart failure. Okay. It can also cause strokes and cause cognitive issues as well. And then whether you have a family history, how did your parents or sibling history is more important than parent history, because siblings have a similar lifestyle. And most of the diseases we have as we get older are lifestyle diseases. It's never too late to start the discussions on preferences and what's important to the person. The earlier you begin having these conversations, the better life is going to be. How many of you all have an advance directive or have discussed about it amongst yourselves and with your family? Good, a few hands showing up, but there's no age limit. My entire family, all of us have it, including my younger sister and everybody. We just made it as one of the Thanksgiving of family discussion. We all siblings spoke amongst ourselves and our spouses were there. And everybody did their advance directives and their DNRs. And all of us are in different states. So, but we did it according to each state. And the good thing is that you're not locked down. This is the only thing where word of mouth is having more weight than a signed paper. Because even in the last minute, if you change your mind and you say, no, I want everything done, even if you said you didn't want everything done, no, I want to, you got a heart attack and you want everything to be done to keep you alive, the doctors will disregard your directive and go by what you've said. So it's not like you're locked down. It's not like you can't change your mind. You can. Okay. Next slide, please. So finding out from the patients if they know what all their diagnoses are and how it affects their life and how it is going to progress, what present or future experiences are most important to live well at that point in life. So I had this 94-year-old patient who had severe pulmonary fibrosis, and he really wanted to celebrate his 100th birthday. He even had cards made and printed and everything, but unfortunately he kept having these pneumonias and kept falling and all that, despite telling him, if your goal is to live to be 100, then you've got to be very realistic about how much you can move and not move and use your oxygen and not go out and get infected. And the pneumonia you have, your lungs are already weak. And he did survive through a lot of hospitalizations and pneumonias, but one time he finally succumbed to it. And when he was in the hospital, his daughter FaceTimed me and asked me to talk to him because he knew he was dying, but he wanted to hear it from me that it's okay to let go. And I told him, don't worry, we will remember you on your 100th birthday and we will celebrate you on your 100th. But it's time to transition and it's time to go. So, whatever the prefer, and the pulmonologist with me, he would say, Dr. Patel, you're being very unrealistic. I said, no, I'm not. I just don't want to take away his hope. If that keeps him going for whatever life he has, why tell him that you're not going to make it to be 100? And I said, neither you nor I know whether he can make it to be 100 or not. So why not just walk the journey with them, supporting them in the way they want to be supported? And and then really when it came time to you know come to face with Jesus, he was ready for it, and he did transition and had a beautiful, they brought him back home and he passed in his home with his wife by his side. And a couple of years later, his wife died, and the daughter made sure that she called my office and informed me that her mother had passed as well. And I do keep in touch with her via text, and I told her, remind me when it's his 100th, we are still going to celebrate it, you know. So what fears or worries they have about illness or medical care. Each one's fears are different. So it's important to have that conversation. And what sustains the patient and family during serious challenges in life. So when they've been sick before, or a parent or a sibling has been ill, how have they coped with it? And how does the family support one another? And is there anything that could be worse than death? I think that is a huge way of understanding the preference of the person and what is important to them. What could be more worse than death for you? Because death we know is guaranteed. Next one, please. So how to encourage educating to be transparent? So we try our best to tell, but physicians are not the best transparent people. I don't think in medical education they teach people about truth telling and how to be empathetically honest with your patient. It's not easy to say, but if you don't say it, then you're not helping them make the right decisions for themselves. And then what to expect, best case scenario, if you do this is how you'll be able to live. And if there are challenges in keeping up with what is expected of you, then this is how it would progress. So that helps the person also understand what their responsibility is. Listing what all resources are available, and then trying to tell what would be the best for the person, where they could start. So many times I'll give the list of resources and I'll say, how can I help you where you want to start? What appeals most to you? Where do you think you want to begin? And let's take it from there. Then building your team, it takes a village. It's not just the doctor's office. It has to be the social support. It has to be the family, drawing in the people. How many times we hold Zoom meetings for our patients and families after hours? 6 p.m., 7 p.m., because different time zones, different places, just to get everybody on board so everybody's on the same page for the person. And also about research and clinical trials. I do ask my patients, especially with advanced dementia and agitation, I run a lot of clinical trials for that because it helps make life better. We don't need to find answers on how to manage agitation in dementia. Then patient and family caregiver, they have a responsibility to list who is important, to make sure their wishes are known, to identify their medical power of attorney. Legal planning is very, very important, and financial planning as well. Next slide, please. So we developed, and I think I've spoken about this model before, so about the Cariños model of care, which is a name that was given to our program by our patients and caregivers. Basically, care, our motto is take care of everybody that walks in our door or the homes we walk into, just the way we would want to be taken care of or our loved ones to be taken care of. Immediately, the compassion and empathy comes in, you know. Advocate for patients and families. We are their voice. Respect what is most important for them. Intentionally redesigning our processes so that we meet the needs of our older adults. Nurtured relationships with everyone, with all our consultants, with families, with the social services. Lisa's our best friend. And APS, I have a lot of the care managers' phones on speed dial on my phone because it's easy for me to reach out and say, hey, I need help here. Okay. But the senior centers, all the DME companies, home health, hospice, they're all our community partners. And really, we go by our patients are wise. Older adults are wise. We really need to listen to what they say. As I mentioned, even if they have cognitive impairment, even if they have dementia, it's important to hear their voice and listen to their wisdom. And supportive care for the patient and the family. It is basically a Spanish term that means fondness, affection, tenderness, and love. That's what our patients who coined the term said. Next slide, please. So this is the model where it starts in the heart with our clinic and our promotoras and our patients and family. And then we have relationship with the ER physicians, with the hospitals. We work with hospitalist groups and give the list of all our PCPs. So if they have any of our patients, then they call us and let us know that they are there. When they're discharging, they give us the transition. We have some relationship with the rehab and long-term care facilities. We have some medical directorships with home health and hospice agencies, so we can continue to have oversight of our patients when they are on that service. Of course, we are with the Alzheimer's Association, Area Agency for Aging, ACOG, APS included, as well as the Cancer Center and all that. The senior centers have been a great partner for us. We go and give these kind of presentations. I usually don't use PowerPoint. I start with everybody sitting in round tables and telling us what they know, and then and then I give material as a resource for them to learn more about it and get more help. And then all the consultants, whether they are with UT or outside of UT, we do reach out to them when the patients are in our office or we are in the patients' homes. Not only me, I have 4 other physicians and 4 nurse practitioners who do home visits, and we're totally 10 in our group. 2 physicians, one does only hospice and one does mainly clinic and nursing home. So we all do the same. We have processes in place and everybody does the same thing. Because being consistent, it's not perfect. We're never going to find a perfect way of doing it. But if we are all doing the same thing, there's less confusion for the patients and families as well. So that's our Cariños model. It has been recognized by the National Institute of Health as a good model for dementia care, and they call it as the Cariños en su casa model, for taking care of persons with dementia and the caregivers. And that resulted in us being a established program for the GUIDE program, which is a CMS value-based care model of care that was introduced last year. We are just about finishing our first year of that program. It is guiding an improved dementia experience. Okay. Support not just for the person, but also for the family. So we used to take care of geriatric patients 65 and older, but found that many of our patients were referrals from Alzheimer's Association and from APS. They found our practice. They would send them first to get the capacity assessed. Or as I said, I have the care managers as my speed dial. So many reach out to me and say, Dr. Patel, how do we get this person into your practice? Because I'm sure they can benefit from what your team does. And so we realized that most of our patients are with dementia, and there's only so many of us. So we tried to focus on 85 and older and just be consultants for the younger ones. And knowing that majority of them have dementia, we decided to focus on brain health primary care. And that's how now we are integrated with the Center for Brain Health. Okay, next slide, please. So you want to develop a relationship. So many as APS workers, you do want to have a relationship. It's not like just checking off boxes and finding out more about the person. What is a day like? And I like the fact that you said you'll go at different times. And I know you'll are really good because the care managers who talk to me know much more about the person than sometimes I do. And what brings a smile to their face? What is their motivation for life? Focus on the M's. Depression, especially you as APS workers, you can really focus on depression. Meaningful socialization, educating that lesser is better, and educating their mobility, and really focusing on what is most important for them. Next slide, please. So to prepare tools for the advanced care planning, this is a great resource, prepareforyourcare.org. It's a free tool, and that really helps with planning and writing down the wishes. Just to let you know, the advanced care planning doesn't happen in one sitting. It's conversations, not just with the physician and their office, but with people, everybody that interacts with them. And over time, they're able to make the decisions known. It's better to do the advanced care planning when they are without any issues, not in the hospital or in rehab or something, than to wait when it's too late. Next slide, please. So how does the supportive care team help? As the disease progresses, needs change, the team helps the person and family understand each stage of the disease. We educate to let them know what to expect so that they can make informed decisions about their future needs and care, such as where to live and who will care and how, and help make decisions on quality of life and focus on issues that are most important to the person. Next slide, please. So what matters most is supportive care, person-centered goals. Each person's story and values is different from the other. Focus on what's most important to the person and be the advocate for the person. Because sometimes the persons let us know they're represented, what is important to them, but their family will try to tell them something else. Another nurse who worked with me many years ago, she called me last night at 8 and said that she's having a challenge. Her oldest sister is her mother's MPOA, and her mother is afraid to disappoint her. Her mother is 90. She doesn't want to go to the hospital anymore. She just got out of rehab, and she really wants to be at home and get the support of a hospice service. But her oldest daughter, who she named as her MPOA, is not ready for hospice, but it's not about the oldest daughter, it's about what mom wants. So really being an advocate for our persons, focusing on the person's preferences, focusing on quality of life and not on the diagnosis, and really talk about advanced care planning for life in every intervention. So, since we all influence the community, I thought I would add a few things about hospice because there's a very negative connotation to hospice. Hospice is a service that is provided by a team of people for hope. You know, you don't ever take away the hope of the person, however sick and ill they are. It's an opportunity to tie up all loose ends. If children have been astray or there have been misunderstandings and anger and, you know, differences in feelings, it's an opportunity to fix that. It's support because it's a very difficult time. You know, if a person dies of a heart attack, stroke, or something, you know, they're not suffering. But if they are slowly dying, as in case of dementia or pulmonary fibrosis or advanced heart failure, then there's a lot of support. There's no, the treatment, the disease is going to keep getting worse, but life is affected. Everyday life is affected and needs a lot of support. And each person's support and needs are different. So it's very person centered. And it's not one person who can do it all, it is the interprofessional team. It's basically compassionate care, care that you would want for yourself if this was the stage you were in, and empathetic. Next slide, please. So it really focuses, talking about what's most important and what matters most, focuses on preferences, values, and wishes, is very patient and family driven, and they have a role to play in this and more likely to be implemented and followed. So most of the times when we have these meetings, we just initiate the meeting and then it's interesting to see how the family talks and they come to a consensus. So we're just facilitating them coming to a decision. It improves both the patient and the family experience and the healthcare team experience in difficult situations. Next slide, please. It has improved the quality of life. And in fact, that was the reason why the Guiding and Improved Dementia Experience program came into being by CMS for 8 years. It respects the wishes and preferences and how you want to live. It improves health outcome, safety, and compliance to prescribed medical treatments. So one of the reasons our model was recognized is when they looked at claims data, they found that the care we provide, the patient outcomes were better and the cost of care was reduced to 1/8 of what other practices similar to ours spend. And so that was one of the main reasons for making it more like a national program. Increased awareness about choices for life. It reduces the incidence of costly ambulance calls and hospitalizations, and it helps the person live with respect and dignity and age in place. The next slide, please. I think this is the last couple of slides. So this is the conceptual shift for palliative care or supportive care. So hospice was a benefit introduced years ago for people who had a terminal diagnosis. But nowadays, really, there is no terminal diagnosis. We all have chronic conditions and can live on. Even people with cancers live on with treatment. Stage 4 cancers can be treated and live for many years after that. So so basically, palliative care is getting the person with serious illnesses sooner, whether it's dementia, whether it's heart failure, whether it's cancer, it is COPD, pulmonary fibrosis, any neurological conditions like Parkinson's, ALS, multiple sclerosis. Start supporting them much sooner. And it really helps with making life better. It reduces the cost of care, and it really helps to focus on life rather than a diagnosis. Next slide, please. So really, advanced care planning and directives are wishes, preferences, and values, and we need to talk about it to our clients because they need to hear about it from more than one source. And where, when, and how to start, it's never too late, and sooner the better. and making shared decisions. Sometimes physicians, most of the times, physicians don't talk about it, but if families ask, then they will have no choice. And social workers and care managers are really good in supporting for this. And the impact is really huge. And the guide program is a great example to show how the impact is used. So despite having a lot of changes in the administration in the last few months, the guide program has stuck on. It hasn't been taken off by the new administration because there is a value to what this does. Okay. I think that's all I have. I'm open to any questions. Yes. Can we use the mic when you have questions so that the audience online can hear also, please?
Thank you. I just could not understand the last part of it, and I'm not sure. I took a lot of notes, but you said so. This program, the guide program, and is that GUIDE?
Yes, it is guiding an improved dementia experience. If you Google it, you will find it on the CMS website, the Center for Medicare and Medicaid Services. It is a program that was introduced last year, July 1. There are some programs that are new programs, and there are some that are established programs, and ours is an established program. The visiting physicians, I think, is a new program. This is a program based on the Carinios model that I told you, that is actually looking at the whole person, not diagnosis, and quality of life, and focusing on the person's preferences. But it also supports the caregivers, because it's not easy to care for an older adult, and not easy to care for an older adult who has cognitive impairment. Any other questions? I don't know if I included my email, if anybody had, but Lisa has my email and she also has my cell phone. So if any of y'all need it, y'all can reach out to me. There's no problem. Okay. Thank you all.
Thank you, Dr. Patel. We always enjoy hearing from you. Right, something a little fun. All right, as I mentioned earlier, one of my favorite things to do at this conference is to talk about and award our Purple Hero Award. This is something that the board has done for the past several years. We select an honored individual in our community with what we call the Purple Hero Award. This award is given in recognition of a significant contribution to the growth and the development in the field of aging, elder abuse, and protective services through their collaborative efforts so that our community is safer for aging adults. So this year's award is, according to their nominator, and I believe the perfect definition of our award. Our hero for 2025 is Miss Brenda Schmachtenberger. And I don't know if she knows it or not. It might be a surprise. Let me tell you a little bit about her as she makes her way up. So for 33 years, Brenda has served the mission of San Antonio Oasis, which is to promote healthy aging through lifelong learning, active lifestyles, and volunteer engagement. From watching this wonderful organization grow to include a membership of over 29,000 individuals, 247 volunteers, and providing more than 1,400 classes, Brenda has been there contributing to these efforts. During COVID, Brenda and her staff contacted each member to make sure that they were doing well and check on them. She was an integral part in creating what we call Silver Connect. I'm sure many of you know about it. It allows seniors to call and connect with a volunteer so that they can hear a kind voice and know that someone cares. So during those past 33 years, Oasis isn't the only agency and nonprofit that she's been involved with. Several others include the Alzheimer's Association, the Bear Senior Advisory Committee, which is part of ACOG. And this year, Brenda is going to be the lead at the Successfully Aging and Living in San Antonio, or SALSA Committee, which is an initiative of the San Antonio Area Foundation. So as Brenda's nominator stated it perfectly, she walks the walk and talks the talk of a true to life purple patriot. So please join me in welcoming and honoring Brenda Schmachtenberger. I want to read this to you. It says, presented to Brenda Schmachtenberger. I did it right. With deep appreciation for your visionary guidance, exemplary leadership, and persevering efforts in making our community safer for all older adults. June 17th, 2025. Want to say anything?
I thought I was coming to help today. Joanne told me to be here at 9 o'clock to help with the salsa table. I had no idea. I don't know where this came from. Thank you all so much for those of you who did this for me. I'm absolutely in shock. So man, you guys can keep a secret. I've had the pleasure of being able to be the Oasis director for 33 years. It's a job that I absolutely loved, working with older adults and helping them have the quality of life that they want. So thank you for this.
I'll give you that so you can sit and stay. All right. We're going to bring to you in between some of our presentations what we call a community spotlight. And it helps us learn about new things, different things, and how our community is changing in our efforts to help aging adults. So the first one we have is, I'm going to introduce to you Miss Megan Frederick. She is the clinical director for UT Health in San Antonio at the Department of Psychiatry and Behavioral Sciences. She's going to talk to us about new opportunities for wellness, or what we call the NOW Clinic.
Hard to follow those last two speakers. So warm and just inviting. This is a great space. My background actually is a lot with working with children. And so I'm really starting to get to know the community that supports individuals with intellectual disabilities and also all of seniors, right? So my name is actually Misty Phelps. I am the project manager for the Transitional Care Clinic, the Now Clinic, and the Now Youth Clinic at UT Health San Antonio. Megan is our clinical director. She wasn't able to be here today, so I am here to talk to you about those clinics. So the first clinic I'm going to tell you about may not be one that you would, hand out to people publicly, but I do think it's important for you to be aware of. We have the Transitional Care Clinic. And so the Transitional Care Clinic is a part of the Department of Psychiatry and Behavioral Health at UT Health San Antonio. Our building is located at 5788 Eckert Road. There used to be a VA there, and it was recently renovated. So it's now the UT Health Behavioral Health and Wellness Center. So the Transitional Care Clinic serves patients that have been inpatient for mental health reasons, or even sometimes for other health reasons, but they are having some sort of mental health concern, like maybe anxiety, depression, to go along with their chronic illness or even their inpatient hospitalization. So the way that we serve patients there is they are referred to us by the hospitals. So University Health does a lot of referrals, Baptist, San Antonio Behavioral Health Hospital, Laurel Ridge, and any other hospitals, SAMC, BAMC, that are discharging people who may need rapid access to mental health services. So like I said, sometimes it is people with actual diagnosed mental illness, but many times it's like somebody who has had maybe a chronic concern and they're experiencing anxiety and depression and they really need to not be on a waiting list, right? That's the goal of the Transitional Care Clinic, is rapid access to care. So they come in and we triage them very quickly, and usually they can see a counselor and or a psychiatrist depending on what they want and what they feel is best for their care within a few days. And they're usually in the Transitional Care Clinic clinic for about 3 months. And we also provide a lot of wraparound services to connect them permanently to whatever needed services. So that is through a hospital referral. I just want y'all to know that that's part of the work that we do. That was actually our first clinic. From that, we were funded for the Now Clinic, which is New Opportunities for Wellness. And that is the clinic that people from the public can pick up the phone and call us. Okay. We serve patients, counseling and psychiatry needs from 11 until end of life. Okay. So we do have a variety of counselors with different specialties. We do have psychiatrists if somebody wants medication management. And then we have a lot of wraparound services. So we do have case management where they can get resources, maybe figure out how to do end of life planning, things like that, right? So any kind of resource needs, and that's on a walk-in basis. So if they're our patient, they can just walk in any day they have an appointment and get extra resource support. We do have peer specialists that are with us from the San Antonio Clubhouse. These are people who have lived experience with either addiction or mental health concerns or even like chronic illnesses that they feel like they've kind of come a long way and that they're able to sort of mentor others with their lived experience. So patients have full access to our peer specialists. People can receive individual counseling, but we also have a variety of groups. So right now, one of our groups that we're trying to stand up, actually, I'm a clinical counselor as well. We are trying to start an older adults group because we are meeting so many individual patients that they're messaging to us as they actually need to be socially connected with others. And so we're trying to do a therapy group for that. So there's a lot of group offerings. Another really cool thing that we have that's very unique is our living room service. So if anybody is a patient anywhere in UT Health, let's say they're Dr. Patel's patient, and they've never even come to our service. If they walk in during our business hours because they are experiencing a high level of emotional distress, they can see a counselor for supportive care. So it is to help a person calm down and kind of figure out strategies to move on with their day. And that's our living room service. Yeah, so I'm trying to think what else. Oh, we also do have family and couples counseling. So many times people start out individually with us and we find out that maybe there's, just like Dr. Patel was talking about, there's maybe some difficulties within the family, some disagreements. We do have people who are specially trained to work with families and couples. Okay. We have some of the other groups that we have that might be of interest to older adults. We have an anxiety depression group. We have a general peer group. We have chronic pain group. I'm trying to think what else. We have so many different groups. PTSD. So we see people who in their maybe earlier lives were in the military and they experienced that. And then we also work very closely with Be Well Texas, which is they primarily serve for drug and alcohol counseling. So when we meet with people with co-occurring disorders, like maybe they have mental health concerns, but also they're dealing with addiction, we can serve them in our clinic. But if they're really primarily dealing more with addiction than mental health, then we'll work really closely with Be Well to make sure they get those services. And the best part about all of this is that we take all insurances. I've never come across an insurance that we've turned away. We do accept Medicaid and Medicare. And then we have gracious funders. So we are partially funded through University Hospital, the Baptist Foundation, and we have a state community mental health grant. And because of those funding sources, we do serve a lot of patients who have no funding. So if they come in, they have no insurance, no Medicaid, no Medicare. Those are the counseling patients that I often see. And I have a large caseload personally of people who are 65 and older as well. So I hope that you guys will think about passing this information along to anybody who's needing mental health or behavioral health services. I do have some flyers. I don't think I brought enough. So I'm going to pass them out and then I'm going to go back to my table and get the rest and I'll come pass them out to the back. Any questions?
I have one. I
Yeah.
have one. Does
Yes.
everybody? Okay. I have one from the chat.
Okay,
So
great.
this is from Amy Byer. And she wanted to know if any of these services are in Spanish.
Yes, we do have Spanish speakers within our physician population and our counseling population. We also have full translation services. So we have a really cool machine that does actually many different languages, up to like 36 different languages, and a translation service as well. So translation is not an issue for us.
Thank you.
Thank you. Any other questions? All right. Oh, my name's Misty Phelps. So like last name like the swimmer, except we're not related. And I'm the project manager. So when you call and the number or email on the flyer, the number is going to get answered by our operator. But if you would send an email to the Now Clinic, I answer that. So if you have any questions whatsoever about the appropriateness of somebody coming our way, we are also able to handle all levels of acuity. So sometimes I know when I've tried to get care for family members outside, there, there's wonderful private practices, but they're able to sort of say, okay, well, we only deal with maybe anxiety, depression, or we only deal with this. We take everything because we are affiliated with the School of Medicine, and we're a training institution as well. And so we have many, many patients with more serious mental illness, even dementia. So we can do bipolar, schizophrenia, and really just try to make it an awesome experience for them. Okay. All right. Thank you, guys.
Thank you, Misty. All right, we are getting ready to start our nice long break. Our virtual attendees will be getting a little bonus presentation, but here in our main ballroom, you are free to move about the cabin. Please visit our exhibitors here and down the hall. Please be back. Let's try to be back at around 11 if we can. We want to start no later than 11:05. It takes a little while to come in. And I'm going to ask you too, as you come and go from this room, no matter even if it's in the middle of a presentation, we want to use this main door here. Some of the other doors have cameras attached that are part of the virtual and that shakes them when we use them. So come through the main door if you would, please. There are still tacos. You can grab them. We've got lunch coming up, but let's eat our tacos. Hydrate. We learned that from Dr. Patel. Enjoy your break, 11 o'clock.
Hello? Hello, how are y'all doing? My name is Daryl Greer, and I'm the Regional Program Manager from OATS from AARP, also known as Senior Planet from AARP. So then now it's going to come to our virtual session program that we have set up for you. And today from today we have Pat Whitty, who is a trainer and has much thought leadership in the field of aging. He has worked as a dean of a university and has impacted many aging nonprofits throughout San Antonio and nationally, including the Modern Elder Academy, Senior Planet from AARP, the San Antonio Area Foundation, and also his own agency that he works with, which is Breaking Age. Pat?
Stick around, that's right. Don't move in now.
Hello? We can't hear. I think you're muted.
Now, oh my gosh.
There you go.
Can y'all hear me now?
Yes, perfect.
Oh, I'm so sorry about that. Wow. Well, let me start back up again. What I started out with was telling you that 43 years ago, I crossed the threshold into the second half of life. And I wasn't too happy about this because, like most people, I was still in the mindset of fearing aging and I didn't want to get older. And I choose to use the term second half of life because I like it better than aging or getting old. Uh, but that's where I am. So you can do the math. If 40 years ago, 43 years ago, I crossed the threshold of 40, it doesn't take long to figure out I'm 83 years old right now. And it's really the best time of my life. But I didn't think it was going to be that way at one point. That's what I want to share with you, some of the things that I've learned along the way. The decades seemed to come faster and faster. Before I knew it, I was into my 60s. And then I entered what's called the dark night of the soul. Now, most people have had their dark night of the soul. We hardly get through life without that. As a matter of fact, it could be said that we have to have the dark night of the soul to become whole, a whole human being. And we usually get through it. But it was not a good time for me. I didn't want it, tried to avoid it. And I remember at that time I saw a clip in a movie called Camelot. And young King Arthur was having a bad time in his life. And he was sitting out in the woods talking to Merlin, the magician. And he said, Merlin, tell me, what do you do for sadness? And Merlin said, learn something. And I thought, wow, that really resonated with me. I said, maybe that's what I need to do. Maybe I need to learn something about myself and about aging. So over the last 6 or 7 years, I've had the opportunity to hang out with some of the world-class thought leaders in the area of aging. And I discovered that there are a lot of people out there who are enjoying what I call flourishing in the later years of their life. Now, that's a word we don't hear very often. But so let's take a look at what we mean by flourishing. This graph I put here just kind of represents the distribution of the population. At the far left are people that would be classified as not okay. They're struggling, they're disconnected, and they're depleted. They are declining. And thank goodness we have these wonderful nonprofit agencies that are doing so much to help people who are not doing okay. But somewhere around the middle of the population, we have, I think most people would gather that would be classified as okay. I'm doing okay. I'm coping. My life is stable. I'm surviving. So after I got out of my dark night of the soul and recovered from that difficult time, that's where I was. I was doing okay, but I wasn't flourishing. And so a very small part of the population, especially as we get older, could be classified as flourishing. In other words, they're connected, they're thriving, and they're living purposeful lives. So I want to talk to you about what I mean by that word flourishing. It's not a word that we use often. We kind of know what that means if we're talking about our garden. We say our garden is flourishing. That means it's growing, the flowers are blooming, the vegetables are healthy. We kind of know what that means, but in the context of human beings, we don't ordinarily use that word flourishing. But when we talk about flourishing as human beings, we're talking about the full realization of our human potential, psychologically, emotionally, and socially. And it involves 5 distinct areas that are within the power of all of us if we choose to pursue it. The first area is finding purpose and meaning in our lives, to live in alignment with our values and to contribute to something larger than ourself. When all we have in our life is ourself, our world is very, very small, and our thinking gets a little bit skewed. So we need a reason to get up in the morning. And that's what I mean by purpose and meaning. Now, it doesn't have to be a Martin Luther King change the world purpose. But it just means that we're doing something in service to people, to something larger than ourselves. So that's the first thing. And that's within the power of all of us, regardless of our age, to find new purpose and meaning in our life. The second area is finding positive emotion and engagement, finding flow. That is doing something that we love so much and we enjoy so much that we lose ourselves in the process. To be curious and to experience gratitude. Those are all things that we can decide to incorporate in our life. Then there's resilience and growth. To look at the challenges of our life as opportunities to grow and to adapt and to learn more about ourselves. Now, here's what I've learned is sometimes we have to repot ourselves. We have to transplant ourselves into a different community. I spent a good part of my life riding motorcycles. As a matter of fact, I still do. But for a long time, I was with, it wasn't an outlaw biker gang, but it was kind of an over-the-hill biker gang. And we had good times together and we rode for big trips. But at one point, I sat up and I said, you know, this community is not serving me well anymore. This community is holding me back because we're talking about the same things over and over and over again, the same attitudes, the same complaints. We're not growing. We're having fun, but we're not expanding our world that much. And so I politely, I separated from that community and found another community. Too many people are allowing their lives to shrink as they get older. Then there's autonomy. It's cultivating agency and learning and the capacity to make meaningful life choices. We have that ability. And then finally, probably one of the most important ones is to find connection and contribution, to build relationships, to engage in communities that support care and development. You know, there's a book recently out called Breaking the Age Code, and Becca Levy is the author. Her research discovered that we can add 7 years to our life simply by adopting a positive attitude toward aging. That's amazing. That's more years to our life than we would gain if we quit smoking. Simply by reframing the way we look at getting older. It doesn't have to be a time of decline. So as I wrap this up, I want to share with you this beautiful line from a poem by Dylan Thomas. And he starts this poem with this line: "The force that through the green fuse drives the flower." And I would suggest to all of us that we all have that force running through us. We have that force that's driving the flower of our life. and we can make choices that help us flourish, to help that flower of our life bloom and bring more joy to ourselves and others if we just make the decision to do it. So these are some things I've learned as I navigated my way through my dark night of the soul and decided I was going to create the circumstances in my life that I wanted rather than just let them happen. And I'm grateful that I did. So what I've done is I've created a nonprofit organization called Breaking Age. You can see the tagline is flourishing in the second half of life. It's a nonprofit 501(c) organization. And what I do is I help individuals break through their limiting mindsets. It's an online community to bring people together, to connect with each other virtually. And what I've created is an oasis of learning and connection where people can go browse and access learning materials, books and videos and writings about life and flourishing. A place to learn and connect with other people. It's a place of online courses. And I also do life transition coaching as we have people who are transitioning either maybe from one decade to the other or retirement. And sometimes people want help in that transition. And the beautiful thing about it is free. It's no cost at all. And I would invite you to consider checking it out. And you can get there in a lot of different ways. One is the URL right there at the top, that tiny URL. The other is the QR code. You can take your camera and you can shoot that right now. And it'll take you right into the community. It's free. There's nothing to sell. It's a nonprofit organization. And then as you're browsing around out there, you go to the Successfully Aging and Living in San Antonio table. And I've got some flyers there on a free online course that's starting up on July 7th. It's called It's Never Too Late to Begin Again. And we'll be reading a book in community and discussing in community this book. Again, free. Pick up that flyer, take a look at it. And I hope I can do my small part to help more people view aging as an opportunity, not a problem. Because it is. It's the best time of our life if we choose to make it that way. Thank you for your attention. Hope to talk to you out there.
Hey, Pat. Thank you so much for those insightful and inspirational words. It was amazing. As always, you are always leading a positive and great way, a great path for us to envision as we age. Now to our next speaker, I'd like to introduce Lori Mars, who is the director of the National Center on Elder Abuse and Elder Abuse Guide for Law Enforcement. She is an assistant professor of clinical family medicine in the Department of Family Medicine at the Keck School of Medicine of USC. After practicing law for over 20 years, Lori's concentration lies at the intersection of law, aging, education, and elder abuse. Ms. Mars has a master's degree in law and alternative dispute resolution and serves as a volunteer long-term care ombudsman. Hi, Lori. How are you doing?
Let me just turn my audio on here. I'm
Hi.
great. Thank you so much, Daryl. Thank you and Lisa and Ann, the whole team, for inviting me here today. It's really an honor to be here and to join this symposium. And wow, what a great speech, great presentation by Pat. That was awesome. And I think a perfect complement to this next conversation. So let's get started on talking about ageism and reframing the conversation on aging and elder abuse. So I have no relationships with any industry pertaining to the presentation to disclose, and now let's get started. So many of us routinely track our daily activities, or we think about doing so. A lot of us count our steps. We have a watch or a Whoop or some sort of fitness tracker. The average person takes 3,000 to 4,000 steps a day. Many of us gauge our food consumption, on average about 3,600 calories a day, even though between 1,600 and 3,000 are recommended. And a lot of us monitor our expenses, even though 61% of US adults don't even have a budget. But the activity that we most commonly engage in is most often unchecked. That's speaking. According to one study, the average person utters approximately 16,000 words each day, and we spend most of our days talking. But how often do we actually think about our words, our communications, and the implications that our words have on those around us? Theologian Abraham Joshua Heschel said, "Speech has power. Words do not fade. What starts out as a sound ends in a deed." And our words are powerful and they can have significant consequences, especially when they're dismissive. So let's turn to the language of ageism. Ageism is one of the most pervasive yet least acknowledged and often socially accepted forms of prejudice. It's an insidious bias that often leads to significant adverse consequences for older people. And it can also be a lens, an inaccurate lens through which we perceive and treat older people. And by definition, ageism refers to the stereotypes, how we think, prejudice, how we feel, and discrimination, how we act towards people on the basis of age. And it stigmatizes people of the same age group as sharing often the same unpleasant characteristics and possessing a diminished level of authority. But ageism is rooted in significant misconceptions. First, a misunderstanding that aging is solely a process of decline. And this is something that Pat alluded to. This focuses on our bodies alone, but it neglects the many ways that we grow and change and evolve over time, intellectually, socially, spiritually, and in numerous other ways. Second, misconception, only older people are aging. How many people in the audience are aging? Everyone is. No matter what age we are all aging. This is common to all of us. And then older people are all the same. Well, we know that's not true. Older people are unique and different. They have different preferences, values, goals, interests around a whole range of things. How many people do you know have the same likes and dislikes, the same capabilities and incapacities, or have experienced the same events and outcomes? We share many similarities, but we're all quite different in significant respects. So let's talk about the words that we use to describe older people, or how do we describe ourselves as we're aging or getting older? Do we use words like experienced, knowledgeable, or wise? Or do some of us use words like dependent, frail, and inept? And then let's turn to how we describe younger people. Are we describing them as vibrant and lively? Or are we describing them as immature and self-centered? Maybe all of the above. But when words have so many meanings, the words themselves can become meaningless. Basically, older people live longer or have lived longer lives, and younger people are those who live for a shorter period of time. All of the other words, those descriptors, they're just characteristics or values or labels that we assign to those words. But those labels have meaning and import and consequences. And these inaccurate constructions of older people can diminish individual aptitudes, personal agency, and truly the vast diversity among the older population. Calling or referring to older people as irrelevant, inept, or invisible can diminish and minimize them. And the reality is far more complex than these reductive words, because truly we are much more than our age. We're intrinsically complex. We have varying histories, backgrounds, and experiences. We differ on where we live, what our jobs are, who our friends are, the way we look, the way we act, what we like to eat, our interests, our goals, our lives. And defining someone just by age alone is really an illusory conception and conclusion. Because as Pat mentioned, elderhood is a time of growth and gain, and we continue to develop and become who we are, redefining life as we age. So let's take a closer look at what happens with ageism and how it has become integrated into the public subconscious. People's attitudes towards and understandings of aging are shaped through social interaction, cultural norms, and behaviors. And these reflected values of older age and aging that are biased are internalized by the public, translated into practice, and converted into reality through recurrent and reinforced narratives. So age prejudice becomes activated, normalized, and legitimized in the public psyche as realized truth. But these ageist values translate into impacts, and those impacts can be quite significant. A University of Michigan study found that of the 50 to 80-year-old respondents who took the survey, 82% experienced one or more forms of everyday ageism in their lives. 65% were exposed to ageist messages. 45% experienced ageism in interpersonal interactions, and 36% internalized that ageist rhetoric onto themselves. Taking a deeper dive on the impact of ageism, stereotypes of older employees as less competent, trainable, efficient, and technologically proficient can hinder our ability to gain employment, attain promotions, and retain jobs. We know that social isolation and loneliness is a huge concern for people across the life course. And it's especially so for older adults whose reserves and resources may erode into later life. But ageism can lead to exclusion and marginalization, and cutting off that critical companionship that is so important to us as we age. Internalized ageism, that self-directed negativity and eroded self-confidence that can manifest in self-deprecating comments where we say, I'm not good enough, or I'm not attractive enough, I'm not smart enough. That can have a serious impact on our psyche, our well-being, and our sense of self-determination. In the healthcare domain, the research has shown us that some providers have been found to disregard or misdiagnose complaints by older patients, focus on disease management rather than disease prevention, or overlook treatment options. And think about it. How often have you accompanied someone to the doctor, an older person, a spouse, a parent, a friend, a partner, and the doctor speaks to you and doesn't address them directly? That can be very defeating. Then when we turn to the financial domain, a study has shown that ageism costs the US $63 billion a year in healthcare expenditures. That is a very powerful statistic. Let's turn now to ageism and elder mistreatment, because ageism doesn't occur in a vacuum. It's part of that larger ecosystem that's embedded in our societal structures that produces social differentiation and division. And when we diminish and degrade and devalue older people, we activate elder mistreatment or foster an environment in which it's more likely to occur. And I'll give you a real life example. This happened in Fort Worth, Texas. In 2017, 20 women who lived in assisted living facilities, all in very close proximity, they died. And they were by and large healthy. There was nothing wrong with them, but their deaths were attributed to natural causes. No one questioned their deaths, not the facility, the staff, the family members, the police, the medical examiner, no one. Until one day, a man broke into the room of a 91-year-old woman, tried to suffocate her, and stole her jewelry. She lived. She lived. She told the police what happened. And after that, the police investigated those 20 earlier deaths. And when they went back and investigated, they found that there were items stolen from every location: jewelry, sentimental items, valuables. And the women themselves, their bodies were found in oddly shaped positions inconsistent with natural deaths. So I ask you, if this were 20-year-olds living in sororities, would those deaths have been investigated? These deaths weren't. Did ageism play any part in the failure to investigate these deaths? Something to consider. So let's turn now to reframing the conversation. And here's just a cartoon on reframing. And this is a negative reframe. We're going to talk about positive reframing, where Bart says, "This is the worst day of my life." And his dad says, "This is the worst day of your life so far." So we're going to turn this on its head and talk about reframing in a positive way, aging and elder abuse. And the first thing that we can do to reframe this conversation is to be more mindful about our own biases and the importance of dismantling harmful preconceptions in our dialogue, our policies, and our practices. Reframing is a communications approach that promotes positive and intentional messaging, focusing on constructive and accurate depictions of older age and aging. How we communicate a message is at least as important as the message itself. And language has the power to shape identities, collective beliefs, and actions. If we talk about and treat older people as a group as frail, dependent, and vulnerable, we're fostering inaccurate and ineffective perceptions of the older community that don't align with older adult abilities. But by centering our collective dialogue on older adult autonomy and contributions, we can shift our understanding of aging, age equality, and abuse prevention, while also invoking our collective responsibility to effect systemic change, promoting the dignity and wellness of the older population. So why should we reframe? By shifting how we talk about aging, we can change public perceptions, encourage proactive policies, and promote a just society where older adults thrive, not just survive. And how does this work? When we change our communications, the way we talk, the things we talk about, that can lead to changes in discourse, into the larger conversation, the communal conversation. Those changes in that conversation can lead to changes in the way we think about things. And when we change the way we think about things, we change our behaviors. That can lead to changes in policy and practice that can better support all of us as a community, and older adults in particular, as we age. So we age well and with dignity. So let's talk about changing the narrative. Some people would refer to aging as the process of decline. Let's reframe that into talking about aging as a time of growth and gain, embracing all of the things life has to offer, thinking about the ways that we grow and develop. And Pat spoke so eloquently about this as flourishing, invoking positive emotion and engagement and resilience. And here we talk about meaning making in later life, all the opportunities that we as individuals can define what meaning making is for us. For some people, it may be continuing in our jobs, doing what we're doing. For some people, it may be climbing a mountain. For other people, it may be spending time with children or grandchildren. Whatever that is, it's meaning making that we can embrace and enjoy in later life. If we focus on older people as the other, or we move older people to the side, we disregard them, then we're missing out on the valuable, rich contributions that older adults make every single day. For example, when people or institutions or companies create products and services for older people, a lot of the time they don't ask older people about their input or their insights. So they don't know. So then products are designed that meet the basic needs of older adults, like security, safety, and surveillance. But they don't address those higher level needs that we all need, like belonging, self-actualization, and opportunities for growth. And this focus is on us. It's on all of us, because we all benefit from that. And then when we view aging as a crisis, that's unproductive. It's inaccurate. It's like the multi-billion dollar cosmetics industry where everything is an anti-aging product. Do we want to think about aging as a crisis, or do we actually want to accurately define aging? Because we are all aging differently. We are all different. And this means something different to each of us. Finite resources. When we think of aging, and so much of the talk during COVID was that older adults are consuming resources without providing a commensurate benefit. This is a very, very narrow view of aging and what older adults contribute to society. But if we focus on involving older adults in the conversation, in the community, and exercising the wealth of knowledge and resources they have, we all benefit. We find solutions. We don't focus on problems. So how do we facilitate accurate conversations about aging? Talk about the process of aging as building momentum. Explain the supports that we need, those age-friendly supports that we need to live meaningful lives as we age. Embracing self-determination, avoiding paternalism. Highlighting solutions and opportunities for engagement. Discussing aging accurately and recognizing ageism as a problem. Aging isn't the problem. Ageism is the problem. And then reframing elder abuse, appealing to our society's shared value of justice, because elder abuse is a justice issue. Propose a solutions-oriented approach to age bias and elder abuse. Elder abuse can be prevented. It just requires a collective engagement of all of us to understand the signs, the risk factors, and to intervene when appropriate. And also to provide those social connections, those age-friendly supports that are beneficial to all of us as a community, and framing elder abuse as that shared concern and boosting the public's sense of efficacy and generating a sense of collective efficacy. So I'm going to share an example with you. A few years ago, AARP did a study on the language that we use when we talk about scams or individuals who've experienced scams. Because AARP found that the language that we use is so unproductive. Engaging in victim blaming and victim shaming. It's not helpful to people. It's extremely harmful, and it derails recovery. For example, let's take this out of the scams domain. If someone breaks into your house and they steal something from you, they've committed one or more crimes. They trespass, there's breaking and entering, robbery, whatever the crimes are in your jurisdiction. They've done those different things. And how are they referred to? They're referred to as criminals. If someone is walking down the street and someone steals their bag, they've stole something from you. They're a thief. But when someone experiences a scam, automatically people use language like they should have known better. They were tricked. They were duped, shaming the victim. But a scam is a crime just like any other. And scammers are extremely well practiced. This is their day job. They know what they're doing. They know what to say. They know exactly what to do and how to appeal to individuals to steal their money, their property, their assets. And I'll give you an example. My father-in-law is 96 years old. He's cognitively intact. He has some physical problems, but cognitively he's intact. 3 years ago, he received a call from someone who purported to be a supervisor for the Department of Water and Power. And they said to him, "You haven't paid your bill. You better pay us right now, or we are turning off the lights in your home immediately." And my father-in-law became concerned, even though he maintains meticulous records. He writes down every bill he receives and he records every time he pays the bill. But the scammer put him in such a state of instability, and they exercise those very common tactics. The purported to have authority, they putting a time element on it, instilling pressure and fear. So my father-in-law was like, okay, what should I do? They told him to go to the store, local store, I think it was Walgreens, to get a gift card, which he did. A 93-year-old driving in such a state, going to get a gift card. I mean, there's a level of cruelty that is amazing in that. He called them back, he gave them the gift card number, and they said, no, that's not enough. You owe us more. Well, Just at that moment, fortuitously, my sister-in-law had walked in and saw what was going on and stopped my father-in-law. But this took a tremendous toll on him. It could have been a lot worse, for sure, but there was the financial loss, which was significant. But maybe as significant for him was that emotional loss, the feeling of I'm losing my independence, or will I lose my independence, or the loss of self-efficacy, the loss of empowerment. That took a very big toll on him. It was only until maybe a week later he came over to my house and my adult daughter was at the table. And she shared about a time when she was scammed. She sent in money to some like internet site and she ordered something and she never received it. And she, by doing that, by having that conversation, it normalized it for my father-in-law. Like, this has just happened to older people, it happens to younger people. And we all feel the same way. We all have the same reaction. This has the same impact. So AARP put this research into action and said, let's shift the focus. We're going to reframe the focus. Instead of using words like scammers tricked you, say scammers are professional criminals, because they are. Instead of saying she was duped into handing over her money, say a criminal stole her life savings, because that's what happened. How could you fall for that? Didn't you see the flags? Or this isn't your fault. You experienced a crime. How much money did you give them? Or how much did the criminal steal? And you should have known it was too good to be true. No, fraudsters use elaborate lies to convince us of their legitimacy. Fraud only happens to older people. No, we know fraud happens to everyone from every background. So I'm sharing with you now some materials from the National Center on Elder Abuse where I work. The image on the left is our older material. The image on the right are newer materials. The one on the left, crisis language, red flags, the language in red, a woman covering her face, someone clasping his hands, and on the right, calmer images, explaining the facts. What are the signs of mistreatment? Report with an affirmation. Don't stand by, stand up to elder abuse. You can make a difference. We want people to engage with the materials. We want people to learn the signs and risk factors. We don't want people to feel threatened by the images or not engage with the images. Separately, we learned that there's some studies that have showed that college students are ageist, or a number of them are. So what do? Were we going to get angry at them? No, we're going to teach them. We're going to share the facts. We're reframing this conversation, and we developed a tip sheet for college students. What is ageism? Who does it impact? How does it impact us as we age? And why should college students get involved? And on the second sheet, what college students do to reduce ageism. And this is a very successful campaign that we had. We went to we're located at the University of Southern California. We went on campus, we engaged students in this initiative, and they were very receptive. So let's turn now to personal frames, positivity and health, which Pat alluded to as well. There are decades of research that ageism impacts health, happiness, and well-being. People that have negative feelings about aging are less likely to recover from illness, more likely to experience depression, have increased biomarkers for Alzheimer's, poor mental health outcomes, and live shorter lives. Older individuals with more positive self-perceptions of aging live, as Pat said, 7.5 years longer than those with less positive perceptions of aging. Higher optimism is associated with more positive self-perception of aging, which can lead to positive health outcomes. Another study found that people with family history of heart disease who also had a positive outlook were 1/3 less likely to have a heart attack or other cardiovascular event within 5 to 25 years than those with a more negative outlook. And then Dr. Becca Levy from Yale said that the single most important factor in determining longevity, more important than gender, income, social background, loneliness, or functional health, is how people think about and approach the idea of old age. So what do? Let's practice reframing, shift the frames, change the narrative, feel empowered, build resiliency, take action, and smile more. A University of Kansas study found that smiling, even fake smiling, reduces heart rate and blood pressure during stressful situations. So I hope you're all smiling right now, or even fake smiling. Can we be part of the solution? Challenge ageist stereotypes about aging, whether directed towards oneself or others. Use respectful, person-centered language with and about older adults. Accurately explain facts relating to elder abuse and aging, and advance solutions-oriented approaches to promote elder rights and justice. So I want to thank you all so much for allowing me to present today, giving me this opportunity to share this symposium with you. Feel free to reach out to us, please, at the National Center on Elder Abuse. We're here to serve as a resource for you. And I have here on the last page a QR code. This is a survey, and I'd very much appreciate if you would take it. It would always helps me to get feedback, to know how I'm doing, and how I can do better in the future. So if you could provide some feedback, that would be very much appreciated. And thank you all so much for allowing me to present.
Thank you so much, Lori. That was such great information and how well it complements all the information that we're sharing today. All right, so it looks like our next portion will start at 11:05. So we have a little bit of time to give folks a little bio break. So at that time, please relax and we will start promptly at 11:05. Thank you and have a great day.
similar to this. Throwing things. 5 wishes. Byron is the founder and leader of Sage Care Management. He is one of our current APS board members, and he's actually a past president of the board. He has over 30 years experience in the social work field. He's recognized as one of the nation's leading experts in geriatric care management and aging life care. So he is going to introduce the rest of the panel members to you. It's going to be a great panel discussion. So please give your attention to them.
Thank you. All right. Well, good morning, everybody. Okay. Well, we get to talk today about ethics. Whose favorite topic is ethics? Okay, thank you. Yeah. A lawyer who likes ethics? Say it isn't so. So we're going to talk about ethics and caregiving through our panel, and we have a phenomenal panel for you today. I have too many pieces of paper. I can't juggle. And so we're going to move this along. It's not moving along. To introduce our panel. There we go. Oh, we're going to introduce everybody. So I get to be your fearless leader, and I'm going to let you guys introduce yourselves in just a minute. So, but we have Jane Pacione, who's the managing director of the Collective Impact through the San Antonio Area Foundation. And then we also have Hunter Morris, who's the assistant criminal district attorney with the Bexar County DA's office. We have Ann Cortez, South District Director for Adult Protective Services. Everybody give Adult Protective Services a big round of applause. Okay. I'm here to celebrate you guys because the work you do is phenomenal, not to diminish any of the work the rest of us do. And then we have Kayla Morales, not Morris, Morales, a research scientist at the UT Health School of Nursing, and she also works with Caring for the Caregiver. I may have butchered that, but I'll let you fix it. Okay. Well, so we're going to just kind of quickly cover why we care about ethics and how we address it and how it affects caregivers specifically. How many people do we have in here that are caregivers or seniors, families, something like that? Okay. Even if you're a professional, right? Some of us, I mean, I'm a caregiver too. How many folks do we have here that work in like the social services realm? Okay, a good number. So I'd ask how many lawyers we have in here, but we really don't care. Just kidding. See, I thought it was just going to be one, so I'm sorry. I didn't mean to insult you. It's hard to insult an attorney. Okay, yeah, why don't sharks bite attorneys, right? That old joke. Professional courtesy. Okay, so we're going to talk quickly that Rosalind Carter, talked about there's only 4 kinds of people in the world. Those who've been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. And I think, right, most of us can say that's very true, right? It's so as each of us works as a caregiver, or each of us have caregiving. Can you advance the slide? Because it's not wanting to do it for me. We ultimately can face some kind of ethical issues in our lives. And so, or in that caregiving, I'm going to need my notes because I'm not that smart. Is it not going forward? Talk amongst yourselves. I'll give you a topic. Civil war, neither civil nor a war. There we go. Thank you. So as a background, and actually we'll let Kayla talk more maybe about statistics, everybody's second favorite topic, is that, so many, oh, talk louder. Speak from my diaphragm is what you're telling me. Okay, I will. You'll never believe it. I was a theater major before I was a psych and social worker, so you'd think I'd know that. So about 34 million provide care to an adult aged 50 or older. There's even more. There's probably another 20 million that then provide care to younger children, some of those disabled, of course. Economic value, over $470 billion, and that statistic was from 2013. So you can imagine it's 12 years old. Average intensity of care, most caregivers provide 24 hours a week of care, right? So working 40 hours a week, then sometimes and adding 24 more hours of work. Majority of caregivers are female, about 75%. 30% of family caregivers who care for a relative also have children under 18. So we have a huge sandwich generation, and I'm probably preaching to the choir, right? Everybody, even if you don't know the numbers, you know these to be true. And then 57% of caregivers report that they do not have a choice about performing clinical tasks. So things like wound care or even just bathing, toileting folks, things that are considered clinical, they just don't have a choice of doing it. So, son's wiping mom's bum, that because nobody else is there to do it. So we additionally have stressors. These cause that caregiving causes. Can you advance one, please? Um, the stressors. It's kind of a threefold. It's physical, it's psychological, and social. So it affects the caregiver's physical health, it affects their mental health, and it affects their social health. And I don't need to necessarily go through all of these. I think, again, most of them are intrinsic. You probably know them, or can figure that out, right? Sleep disturbances. The mental health aspect, though, is the one where we talk, where we suddenly sometimes get APS involved, right? That's where, when the stress becomes too much, and the physical and the social, when those disappear, when we're too tired, when our health is affected, when we're gaining weight, we're losing weight because of the caregiving, and when we're losing our social connections, right? When we've stopped going out with friends, we've stopped doing things, when we've isolated ourselves, and we're not doing the things that kind of fill our cup, then our mental health starts to suffer, and we start getting, that anxiety, that depression, anger and resentment. And so any of those, any of those things can stress out a caregiver and then create some kind of ethical issue that happens. And I don't love the term ethical dilemma. We could go into ethical dilemmas when you have two right choices. So an ethical issue is when we just have something that kind of feels icky. Ethics are mercurial. And we'll talk about it in just a minute, some of the ways we look at ethics. But everybody has just a little bit different way of looking at ethics, and that doesn't mean your ethics are bad and my ethics are good. We usually have a common thread, but they're not always exactly the same. And so ethical issues that often kind of stress out family caregivers is the absence of boundaries, right? That I don't have a choice but taking care of my mother, that feeling of kind of enmeshment. I don't want to be this close. I don't know about anybody else, right? We work with clients who feel an obligation, right? Mom or dad was not the best person when I was growing up. They were an alcoholic. They mistreated us. We have a client who actually APS found them and found her brother. That was the one, they had not been in contact in 30 years. Her two daughters want nothing to do with her, and they've had nothing to do with her for over 30 years. And so now this brother has come in and he's helping, but he feels guilty. He feels kind of anger that he's been, sucked in, but he feels a duty. And so there's an ethical problem there because Is he always going to do the right thing? Maybe not, because he might do some things out of frustration. Um, Decision autonomy, power dynamics. The power dynamic is one of the things that I always think I always think about when we're talking about, especially family caregivers and even professional caregivers, right? There is a power. If I'm the person you rely on to get your food and to get out of bed and to feel clean and to just get moving in your day, I have a lot of power over you. And that even if I'm not abusing it, I hope, right? You hope people don't, but there is a power differential, and that power differential has usually shifted, right? Parents usually have some kind of power and control. Do this because I said so. I'm your parent. I'll always be your parent. I'll always be bigger and better than you. But hopefully your parents didn't sound like that. Mine did not. Sorry, that was a caricature. But now the power differential has switched, and so you have the child, or again sometimes a professional caregiver who is kind of taking on that power role, and that can be abused and it can cause ethical problems. So I'm going to quickly kind of populate all of these so we don't have to. Sometimes when I'm building slides, I think if I don't know what I'm talking about, at least if I make it move, it'll make it look like I know what I'm talking about. And I think this is probably one of those. So this is a social work. Do we have any social workers in here? Oh, yay, a whole bunch. All right. Well, hopefully you learned Dahlgren and Lowenberg's kind of ethical principle screen. You may have learned something different, but I like this one. And so we can run kind of decisions through here, through this screening. And while, again, many of you aren't social workers, I think it still applies, right? You're going to look at this and kind of go, wow, if I have to, I get a call from a neighbor and my mom's on the floor and she's bleeding and she's screaming in pain. I mean, protection of life is the first thing I'm gonna hopefully make sure she's got 911. We're gonna get her patched up. Um, and then we look at equality and inequality. And so like people are equal and unlike people are unequal, and it's okay. And so in adult protective services, well, I'm not adult protective services, but in adult protective services, they're protecting the vulnerable, and so they're unequal, and so they get special protection. They don't get equality, they get inequality, so they get special treatment. So children, adults with disabilities, and older adults, we treat them with different rules, and so we're allowed to. That's where we get through here, and we say, wait a minute, if I get down to this point and I'm having to make a decision, are they a special class? Right? Is this an elderly person being abused? And so if I have made it to autonomy and freedom or privacy and confidentiality, some of those things are going to fly out the window because this person has a special need, right? I'm going to treat them differently than I would treat somebody else in almost the exact same situation. Hopefully that makes sense. So we can kind of run through those, but I think I've made my point, and I want to leave time. I want to leave plenty of time for us. But I do want to compare it real quickly to a medical model. And so I think sometimes this is where we run into problems when we talk about caregiving and stressors. So I really believe that most people out in the community, most adult children, most caregivers kind of work off of a social model of justice and ethical principles. And I'm not saying that do we have any medical professionals in here? Doctors, nurses, physical therapists, anybody that works from a medical model. Folks that tend to work from a medical model are taught a little bit differently, and they're taught this, and some of them line up, but the justice, respect for autonomy, non-maleficence, right? First do no harm, and then beneficence. And they're not ordered. That all four have to be met for like your physician to feel like he's running an ethical practice, and that's really hard. And so many times difficult choices have to be made in caregiving, at end of life. All sorts of different issues have to be made, and a medical model sometimes gets us stuck. And that's why, you know, we sometimes see in hospitals we get stuck. We get stuck with a decision that I can cure them, I can heal them. Is that the right choice? Or well, we should just, you know, they're 90 years old, we should just let them go. No, wait, hey, wait a minute. There's some there's some other issues. So, okay. With that, we're going to kind of skip to our case scenarios. And does anybody have any questions about the ethics issues so far? No? Okay. I covered it very quickly, so sorry. So we have some case scenarios, and we're going to let our illustrious panel introduce themselves first. So I'm going to kind of hit Jane first. Oh, no, I'm going to hit Kayla first. Kayla, can you introduce yourself and comment on where you think current research in caregiving and potential tools are to help the caregiver?
Good morning. Um, Thank you for having me. So my name is Kayla Morales. I'm a research scientist at UT Health San Antonio School of Nursing and also part of the Caring for the Caregiver program, where I work alongside Dr. Roxana Delgado. Her research primarily focuses on military health and integrating caregivers into healthcare systems. My background is in medical anthropology with a focus on the needs of older adults during times of crisis and disaster and post-disaster care. So current research increasingly indicates that caregiving, as we know, is not a one size fits all experience, right? It's very layered and it's a dynamic journey. So part of our research involves mapping out the unique challenges that caregivers face. So for example, navigating complicated healthcare systems and supporting loved ones with complex physical and psychological needs. Research also helps us to uncover the important gaps in care, such as lack of access to coordinated care or the emotional toll of long-term caregiving. So what we see, for example, is, as Byron mentioned, all those the toll, the physical and emotional toll that caregiving takes on the caregiver also has a negative impact on the quality of life of the loved one, of the care recipient. So it's important to kind of treat both of them, not just the loved one with the condition, so if they have dementia, but also take into consideration support for the caregiver as well. So as for tools, on one end, of course, there's a lot of technology that is useful, like mobile apps for tracking care or virtual peer support, especially for caregivers who may also be in the workforce and have difficulty attending things and may need support after hours. So this offers them flexibility, but then we also need to focus on stronger in-person infrastructure. So including things like respite care for caregivers, care navigators, and also focus on culturally adapted resources for caregivers. And most importantly, what we really need are systems and policies that recognize caregivers as part of that care team because they are involved in the decision making of their loved one. And ultimately, what we see is that research should and can help move this from simply identifying just the caregiver burden and what it is they're dealing with, but to really designing systems that actively support their strength and resilience as caregivers to improve the quality of life and health of the care recipient as well as for the caregiver. Thank you.
Thank you. All right, and then so Jane Pacione, introduce yourself and explain how a collective impact movement can improve care.
Yes, I'm Jane Pacione. I work for the San Antonio Area Foundation, and I lead an initiative called Successfully Aging and Living in San Antonio. So SALSA gets pretty hot and spicy. We look at things like caregiving and social connectedness and transportation and housing and all those, how those things affect people in older life, because the wonderful thing is we are all aging. And so collective impact is a way for many organizations to get together and work on one thing, have one North Star. So we have 65 plus organizations, about 120, 30 people working in this aging space and looking at what can we do in housing, what can we do in transportation, what should we be doing in social connectedness. And just to let you know that if we're looking at transportation, Americans outlive their driving abilities by 7 to 10 years, right? If we're looking at caregiving, we are looking at a care economy that's in crisis. When we're looking at housing, also, we're knowing that the people who are becoming homeless now are older adults for the first time. So just like I always say, that Eric at the food bank, he's the CEO at the food bank, he is not going to solve food insecurity in San Antonio. It's everyone, it's all of us. So collective impact is a way for us all to work together towards one North Star so that we can build efficiencies and change systems, because very often systems get in the way.
And to kind of put a nail in that all of them are intertwined, right? Just because the caregiving crisis of the fact that I can't drive, now the caregiving and the housing, everything affects everything else. Yeah. So, okay, Hunter, we have Hunter here from the DA's office, and please introduce yourself, kind of talk about some of the legal implications of caregiving and ethics, and do ethical issues always become legal issues?
Hi, I'm Hunter, and I am the Assistant District Attorney here in Bear County, specifically for financial exploitation of elderly individuals. So I do kind of tangentially and through trainings interact with training materials and folks on elder abuse, physical abuse. I primarily focus on financial, so bear that in mind. My opinions today are of my own. But it's interesting because in Texas, generally, just as a matter of course, adults going about their business don't have like an affirmative duty to act, right? Unless they assume that duty. And so caregivers are in an interesting situation because you are assuming a duty. And when you assume that duty, you have certain responsibilities placed on you. But not always will an ethical concern rise to a legal concern. And I think the majority of the time, I would like to think for most of us that our ethics are well above that legal threshold. And so I think for the most part, if you're acting ethically and you're caretaking with your communication, your responsibility to your patient, making sure their needs are met, et cetera, based on their individual circumstances, you're probably going to go far and above and beyond what's required of you legally, right? It takes generally a pretty big breakdown in ethical responsibility to somebody before you start meeting that legal. But that's not always, right? There are exceptions. As Byron said, there's a spectrum of ethics. We don't all have the same ethics, but we'd like to think that we would all like the best for our patients. I think that you can run into issues ethically, but maybe not legally when you have early on breakdowns in communication. So let's say you're a caregiver and you're in someone's physical home, so their residence, not an assisted living facility or an independent living facility, but let's say you were in somebody's home and you start to have a breakdown in communication, whether that's a personality issue that you're encountering with the patient suffering from some kind of physical disability that's degenerative, and so they just are unable to comply, whatever the case may be. Some of those things are easier to detect that you could pick up on ethically. Like, I see this is a problem now. It's not a legal problem, but it could become a legal problem. And so you have to step in and make some adjustments accordingly. If there's a need for different care, more care, or just somebody else to step in and help facilitate that communication, may not rise to a legal issue, but it may in the future become a legal issue if there becomes a lapse in care, a lapse in caretaking, or injury, some kind of financial loss, etc. I tend, in what I do, because I do financial elder abuse, what I tend to see the most issues in are the financial exploitation aspect of it. And so, my word of caution would be, if you find yourself in a caretaking position, a lot of times what I see is that to facilitate the transfer of funds, the payment of bills, et cetera, the caretaker will be added onto bank accounts, be made statutory durable power of attorney, and other things. And so the caution is, know yourself as a caretaker when you're going into it, right? If having access and the ability to access all of those funds and all of those things would be a temptation for you, whether that's just human nature or not, like, know yourself, right? Take as much access as you need to do your job as a caretaker, but I would caution you against just getting it all because it will make it easier, right? If there's a problem and there's hardship, and so you have to do something to facilitate payment, caretaking, et cetera, that's one thing, right? But I would caution you against just jumping in, going all in, because anybody that's looking in on those finances, anybody that may have an interest in those finances at some point is going to be highly critical if they don't like what they're seeing. And so that would be my word of caution. But the big takeaway is that no, ethical concerns don't always rise to legal concerns. And I think we'll probably touch on some examples later.
Thank you, Hunt. Okay, so last but definitely not least, we have Ann Cortez. If you can introduce yourself, of course, and then where does APS see most issues kind of in that ethical screening with caregivers and care recipients, and how is it that APS is able to address any or all of them?
Well, good morning again, everyone. I am Ann Cortez, and I've been with Adult Protective Services about 37 years. So I have had some experience in dealing with these situations and dilemmas throughout my career. From my perspective and the tool that you all saw earlier, the middle piece of the spectrum is autonomy and freedom, least harm, and quality of life. And that has to do with the level and ability of our elder person, we call them clients, ability to make decisions. In Texas, adults have the right to self-determination. And that is a critical and key factor for adult protective services. In the scenarios that we're going to be going through, we have to weigh that ability to make decisions and the right to self-determination versus the current situation and safety and harm. You can make a bad decision in Texas if you're an adult, and as the doctor mentioned earlier, making a bad decision isn't necessarily abuse or self-neglect. It's a bad decision. So when you're looking at the hierarchy here, the autonomy and freedom, harming yourself or others, and quality of life from the APS perspective is what causes, we believe, some ethical dilemmas in that the client, the family, adult protective services, community resources, we would all have to take into account and start with where the client is at, the client's choices, the ability to make that choice, and what are some of the unintended consequences of those choices that adults make.
Perfect. All right, so we're going to jump into some case scenarios and kind of get some opinions from folks. So we have a 78-year-old woman who lives alone. She does not drive, and she depends on an electric scooter to get her around her home. She has one daughter in the area on whom she depends to take her to appointments, run errands, which includes buying her groceries. The daughter learns that her mother has been ordering alcohol to be delivered in large amounts, which contributes to her health decline. Her mother realizes she cannot afford delivery charges, which is probably how the daughter found out. And so she asks the daughter to buy the alcohol for her. So, we purposely didn't put on that the daughter agrees or disagrees, right? Because it's going to be different for everybody. But so how do we balance mom's desire for, alcohol and contributing to her decline? So I don't know if if APS wants to take the first stab, or if anybody else has, because I think sometimes, well, I'll throw in my own opinion, right? I think that many times what I hear from colleagues is, why isn't APS doing something? And it's, fortunately, I think I have little insider knowledge, and I'm like, because that's not their job. I think we expect too much of you guys.
Well, we're not the moral police. And we don't want to be. You're right, that is not our job, and it's out of our scope. And so, like Hunter said earlier, these are the opinions of Ann Cortez, not necessarily Adult Protective Services. So a part of me is like, she's 78 years old, let her drink. But quite frankly, there are other risk factors that we would get involved in. I would tell you, just based on this scenario, it wouldn't be a case for adult protective services. What would need to happen is that they're wandering at night. They're riding around on their scooter down the street. They're placing themselves at risk and or harm. And so on the surface, APS would probably not get involved in this particular case. If there are harm issues, self-neglect issues, there is a possibility that adult protective services would get involved. It doesn't look like the daughter, who's the caregiver, lives, she lives alone. So for us, it would be negotiation. We would recommend that, you look at the adult, their capacity ability. There is an underlying reason. I mean, were they always drinkers, or did it just become drinkers, or are they having trouble sleeping? I mean, part of APS's role is to conduct an investigation and determine what the root cause of this situation is. Is this a new occurrence? Is this a historical occurrence? When they did drive, did they go pick up their alcohol and now it's just because they don't have the ability to drive? Were they spending $100? If you look at historically, they've always spent $100 a month on alcohol, and it's still $100 a month. And I just think you could best spend your $100 elsewhere, where that's not my role. Did it jump from $100 a month to $500 a month? And are they placing themselves at risk? So from an ethical standpoint for APS, we would ask all of those questions. Now, if mom, 78 years old, and has for her faculties and tells adult protective services, mind your business, I can do what I want to do with my money and my alcohol, APS would have to mind their business. Very early on in my career, I had a case where it was a elderly gentleman. He was a veteran and drank excessively, and almost like this case would have it delivered. The issue with APS is that he was in a high-rise facility, and he smoked, and so he smoked in bed. And I was going in, I was young at one time in my life, and I was a young caseworker, and tried to tell him he needed to stop drinking and smoking. And he told me that he'd been drinking longer than I was alive, and that nobody was going to keep him from drinking. And he had a point. I mean, we had other issues with the smoking in bed and what have you, but from the APS perspective, in this particular scenario, we would have to be asking a lot of questions and respect their right to self-determination, if in fact they do have the right to make that.
I'm going to add something from a carer's point of view. This scenario could actually be my family. So my sister had this very thing. She didn't want to buy my dad alcohol. He wasn't driving. He drank a lot. But you know what my sister did? Instead of trying to navigate this on her own, she picked up the phone, called me, and said, hey, this is happening. And very often, I think caregivers are in that space where they're very isolated, and then they're toying with these very big things in here, which may be morally against what they think, but self-determination is where it's at. And as a person who has been a caregiver and a care receiver, I want to do what I want to do when I want to do it. And if I can communicate, I know what's going to happen if I keep doing this, and I understand that, and you know that I understand that, then what more is there to do, right? But this happens in families all over the world, not just America, all over the world. This is happening, decisions today. People, I don't want to do this, but my dad had drank for years, and I say, this is the time to bring other people into this. I told my sister, hey, let's go and talk to the doctor and see if an increase in this, what would that happen? You know what I mean? Get other people in this, make other people the bad guys in this scenario, right? So it's not just the sister, but it's the doctor said. You know what the doctor said? Oh my goodness, So I think caregiving really is something that should be done as teams. And unfortunately or fortunately, it used to be caregiving was a minor sprint, right? You would get someone at the end of life, who needed a little bit of care, and boom. Now, with all the healthcare breakthroughs and technology, it's a marathon. And many of us aren't trained to be marathon runners in this thing called caregiving, which is so complex.
I was just gonna say, one other option that someone in my dementia support group that I've been a part of for a long time did was, she just, with her husband, she just started diluting it. So she bought it, just diluted it as slowly as much as she could get away with, and just trying to give him, he had dementia, and just trying to give him what he wanted, but maybe not as much of what he wanted.
Yeah, I think when you're talking decisional capacity, and maybe Hunter, I don't know if you can talk about a legality. If I'm I mean, again, in this scenario, right, we have very little information. So if we start tacking on, oh, well, wait, she's very demented, or oh, wait, there's $1 million involved, and I don't know. I don't know if you have any input on a legal. Do I have a legal duty to keep her from drinking?
Well, assuming based on this hypothetical, I don't see any indication that there's any cognitive decline. It's just a physical restriction. That she is fully capable of making the choice to drink herself into oblivion if she wants to, absent any legal intervention. So it would really just be on me as the caretaker ethically to decide, and what I would need to communicate to her, if this is something I'm willing to do for her or unwilling to do for her, and make that known. So if I'm unwilling to do it, then perhaps I need to be looking at alternatives, somebody else to fill this role if she insists on getting the alcohol. Because I don't want to show up at HEB or Specs, whatever the case may be, thinking I'm picking up groceries and they bring out a few 30s also. And then, what do I do? Leave them there? And then you have your own kind of dilemma in that moment, because it's been paid for. So if this is a situation as it reads, as the facts read, I don't think there's anything I can do to prohibit her from drinking if she has the full ability to make that decision on her own. But it probably is an ethical question whether or not I'm willing to furnish it.
I think just to add, to echo what Anne and Jane said, is just trying to have an open conversation. And if the daughter isn't ready to have that, or doesn't know how to have that conversation herself, bringing in healthcare providers, social workers, someone to help navigate that conversation to try to get to the root of the problem. Because often if someone's drinking like that, especially someone who has a major life change like a mobility restriction, it's not just that they want to drink, it's something, a larger issue that may be able to be dealt with other kinds of resources and services.
Yeah, good point, good point. Yeah.
Yeah, Hunter, when do you have an ethical obligation to refer somebody for perhaps an involuntary commitment or a guardianship if they pose a threat to themselves or others? And this could be a threat to herself if she's drinking herself silly into a stupor, or alcohol toxicity, for example, if she's drinking that much. Do you have a responsibility to refer it for some kind of civil remedy, not necessarily a criminal remedy?
Well, I think as a matter of course, if I'm a caretaker and I see somebody that is fully capable of making the choice but still actively harming themselves, I'm going to let somebody know. So let her physician know, let anybody else in her sphere know that's been somewhat involved with her caretaking or her well-being. Do I have a duty? So like, if you yourself in your full capacity were living at home and you maybe weren't able to go out and buy your stuff, but otherwise living by yourself independently, want to drink yourself and make yourself sick on drinking, I mean, can a court force you to do it? I think you would have to have some kind of showing that the person, there's something else going on. There's an ailment. There's some kind of degeneration that is causing it, because they have that autonomy to make those decisions in their own home. Are they going to harm themselves? I mean, that's a question, and maybe a court would agree that they are actively harming themselves. But I think if they have full capacity and the autonomy, living by themselves in their own home, making that decision to actively drink, if we are seeing them actively harm themselves and they're having to go to the doctor, then sure, that will probably trigger some additional inquiry, right? But if they're just drinking a lot and have this like long-term fear that they're going to harm their liver, like, I probably can't get a court to intervene there. I mean, I can't imagine how many adults are in that situation, but if there's some noted decline, or there's some other like intervening situation or circumstance that gives me cause for concern that maybe they're not making this decision entirely voluntarily, then sure. I mean, I don't know if that would rise to a legal obligation if I'm not like a live-in caretaker and I'm just a family member that's being asked to deliver alcohol. But I think ethically, as that family member, I'm letting somebody know. Does that answer your question?
For the most part, but you as a professional,
Mm-hmm.
you know, we have obligations. If we see abuse, we have an obligation to report.
Sure.
Do you have an obligation to seek some kind of civil remedy other than a criminal remedy? That's a serious thing to take somebody to a grand jury, for example.
Well, there's certain situations, like if we're in like a care facility, then the human resources code, the government code, the penal code, I mean, they do make affirmative duties to report, et cetera, if you see something happening in those situations. But I'm not aware of a particular statute that imposes a duty on me as a prosecutor to report to somebody if I suspect, again, because I have no personal contact, if I suspect that maybe somebody's drinking too much and causing harm to themselves in their own home, absent some other indicator of decline or circumstance that would make that somewhat involuntary.
Would like to remind folks, as I see Ann scowling, who has a duty to report suspected abuse or neglect in the state of Texas? Yeah, everybody, everybody, everybody. If you're over the age of 18, you have a duty to report. And I'm not saying that I think we were talking a little differently here for sure. But I do want to remind folks, right, that if you suspect, you don't have to do the investigation. You don't have to do anything. You can call, your hotline's going to light up now, right, with everybody. My neighbor has gravel in her front yard. I think you need to investigate. Mike.
Session, they passed some legislation that did away with anonymous reporting, but that was just for child protective services. So for adult protective services, they still accept anonymous reports. So in whatever setting you're at, if in CPS, they no longer accept anonymous reports, but in adult protective services, they still do.
Yeah. Okay. Well, let's move to case scenario 2. And this we'll probably stop here. Yeah. Yeah. Someone online has a comment.
Sorry, thank you. This is from Utunde Taiwo, and they mention the rational aspect of my mind advises me to proceed based on facts and logic, thereby concluding that continued access to alcoholic beverages is unequivocally inadvisable, particularly in the light of research that outlines the detrimental effects of alcohol on health, especially for individuals managing comorbidities. Conversely, the emotional aspect may influence my decision-making, potentially leading to a suboptimal outcome. However, by operating from a balanced perspective, I can acknowledge the emotions while also considering established facts. This approach involves employing active listening, validating concerns, exploring exploring healthier outcomes, exploring healthier coping mechanisms and considering treatment options to mitigate cravings. I hope that makes sense.
There you go. Okay. Well, case scenario 2. Your father has been living at home with paid caregivers assisting him. His favorite caregiver has been with him for over 5 years. You learned he has loaned her $150 to get her car fixed. What is your initial reaction? I think probably as a caregiver. Anyone?
Okay, this is a tough one because you know how hard it is to get a really good caregiver. It's really hard. So, and it sounds like this parent has already forged a strong relationship, and it's $150. And then I'm thinking about transportation. If he didn't lend her the $150, could she have given him the care that, you know, so I'm just looking at all these. But I do go OMG at the very beginning and I would think that we would need conversations with both. And I'm assuming it's not with any cognitive decline, right? And I think there needs to be agreement, financial agreement, that if there is any money transfer, maybe it needs to be a family discussion, right? To really protect the caregiver too, not just the family member, but the caregiver too, because I really do think it's, you know, a slippery slope. But if this person had any type of cognitive decline, I would want financial protections immediately, especially if it has any dementia or cognitive decline and it's a larger sum of money. So I think, you know, this is the beginning. This may be, maybe not, the beginning of something. And how you act on this one thing that you might think is not too big right now, and that your dad really wanted to do, could be the start of something. So I think coming in and having a nice conversation with clear communication that everybody knows, you asked dad for this, he did that, that's great. In the future, I need us to be discussing this together to protect you and to protect my dad.
And so, yeah, I was going to say, so, you know, maybe even you can answer the same question, kind of initial reactions, but also do you kind of hit the nail on the question, hit the head on the nail of the question. I don't know. That's a thing. But that does your opinion change? Do the facts change? Does your reaction change if it's more money, if he's giving her some of your mom's jewelry, if there's, right? If there's, I mean, we had a client buy a caregiver a car. And yeah, I thank you, Hunter. His eyebrows went up. And so, and then of course, what happens if there is, you know, some signs of cognitive, very clear signs, or even a diagnosis? Obviously, that's even further, a diagnosis of some sort of cognitive decline.
This happens very, very often. And from an APS perspective, and I've got some staff here that probably know this better than I do, if you're a paid caregiver, Adult Protective Services would not investigate that piece. And then there's a whole statute with respect to theft and, you know, theft versus exploitation. My recommendation from an APS perspective is it goes along the lines as what Jane was talking about. You need to start having a conversation. It is very difficult to find good caregivers. And is this a caregiver that was sent from the agency? I have a caregiver right now for my IDD brother who's been with us 21 years. And so it's a very different relationship after they've been with your family for 21 years versus someone, you know, you have a client that runs off the caregiver every other day and, you know, you're getting new caregivers. This happens more often than not. And the presentations that you had early on with respect to end of life planning, will planning, who owns the home, who owns the items in the home, all of those discussions should be happening early on. Because again, at the end of the day, if there was, you know, if there is no form of dementia, and dad owns everything and he wants to give it away, he can give it away if he is in his, you know, if he has capacity to consent, there's no dementia issues, and we have long-standing court cases with very wealthy people who give it away. And so all of this has to, pre-planning is important. Discussions are important. If you are children and you're hiring caregivers for your parents, due diligence with respect to who you're hiring. It's not going to keep them from, you know, not borrowing $150 or co-signing on a loan, buying vehicles, co-signing on credit cards, putting them on their account. I mean, if you can imagine it, it happens. Um, so pre-plan, have conversations, determine whether it's a paid caregiver or not, and have those conversations early, even when you're interviewing caregivers for your family members. You interview them and you bring up the subject before it even comes up. This isn't something that is that we're going to tolerate in this home. So you need to have these conversations because there are some things that adult protective services can get involved in, and then there are others where it's theft, it's not an APS case, where it's a paid caregiver, it's not an APS case, and so you need to have those conversations early on.
So my initial reaction is just curiosity. In a lot of these cases, we have to work backwards. And it says that she found out that there were $150 loan to get the car fixed. So my first question would be, well, how did she find out? Is this something that she noticed when she's scouring his bank records? Did somebody bring this up to her? If somebody brought it up to her, then why did this person think it was worth bringing up? Is there some other concern? Is this $150 like the tip of the iceberg? Or is just, I happen to notice that he loaned this money? Because it's kind of unusual that somebody outside of their immediate sphere would have any idea that this is happening. So if I'm in that position, then I probably do try and have a conversation with the father, and it doesn't have to be direct. And be like, was she able to get her car fixed? Just something indirect, just curious, inquiring. And then if I suspect, if there's a question about capacity, but not just capacity, but if there is a capacity issue that a geriatric psychiatrist can say has an effect on one's decision-making ability or executive function that can tie us to these types of decisions, then I can try and figure out, was even this $150 done fully and voluntarily? Or is there something else at play that contributed to this that otherwise would not have happened? So is it being spent on what it's claiming to be spent on? Does he aware of it? If he has full capacity, or if there's a loss of capacity, but that loss is not tieable to the ability to manage funds, and he has that full capability, then I would probably just keep an eye on it. I would keep an eye on it. If I have access to records, I would just keep an eye on the records. If I suspected that there was any kind of maleficence, if you put it, or any additional funds that are being moved around, then I would definitely notify APS or notify law enforcement, depending on the nature of the issue.
Yeah, because my concern again goes back to that balance of power. And I think sometimes, and I think you guys, got that, I want to make sure this isn't something, I think certainly we see it grow, right? All of it, everybody here, where it starts out as $150 and then it turns into, well, she's now the recipient on the will. Yeah, she's the only, so. Okay, well, let's move on real quickly, kind of, if we can, to scenario 3. Maybe. Let's try. Everybody wish really hard on a star. Yay, it worked. Okay. A caregiver daughter is frustrated with her mother's inability to listen. She shouts at her when she refuses, let's even say screams at her, when she refuses to take a shower, eat certain things, go to sleep at certain times. So she's yelling at her about her inability to help her in the care. Is this abuse? What additional information do you want to know? As a mandated reporter, do you make a report to APS? Do you give the daughter a grace period? What are some of the implications that you guys see? And I'll start. Myra's been very silent, so I'm gonna pick on Myra and let her start.
So I think this is a tough situation. It's very common as well, though. I think as caregivers, somebody who's had to be a caregiver and been around other caregivers, I've seen this a lot. I think there's definitely a point when shouting can cross into verbal abuse, especially if it's something that's persistent, if it's a pattern. But we also need to understand the context. So is this a burned out daughter who's trying her best to support and trying to cope with dementia related behaviors? Does she have any additional support, a support system to also help her, or is she doing it all on her own? It's something that she might not understand how to deal with, the dementia related behaviors, because a lot of the times you just become a caregiver. It's not something that there's no really transition. It's just an overnight thing.
When you
Many
pass the
times.
course, you're in. Yeah.
Exactly. So I'd want to understand that context and have more information before immediately calling APS. If there are no apparent urgent safety issues otherwise, to give that daughter a grace period, but also pairing that with providing resources like caregiver training or respite support if available to try to help de-escalate the situation and prevent further harm. Because I think we have a responsibility, yes, to protect the older adult, but also to recognize when caregivers need support. Like I mentioned earlier, a lot of times we have to think about that dyad, about the care recipient and the caregiver. They're a system, they come together. So what affects one affects the other. So what can we do as, other organizations that work with caregivers to try to give them that training that most of them don't get? What do they need, whether it be, counseling or family therapy or a social worker coming in and kind of helping them, educate them about dementia related behaviors. So I think providing those resources would help in this situation.
Okay, perfect. Yes.
Well, I feel like I'm giving a standard answer that, from a APS perspective, we look at backgrounds as this, behavior that they have interacted with one another that way all their lives. Again, it's very common. Oftentimes, in some situations, you have one sibling living with the aging parent and the other siblings don't like the way that their sibling is taking care of their mom, but they don't want to help out and do it either. So it's very easy to say, Anne's a little rude to my mother, but I, I'm busy, I'm working, I have kid, et cetera, et cetera. So I can't offer any help. The other issue is, we have situations where the caregiver has mental health issues. And so those mental health issues are either undiagnosed or not treated. And so it's a very complex situation. The other issue that we face with adult protective services and dilemmas is that they're the only caregiver in town. And absent of that caregiver, that the vulnerable adult can't live alone. And so they would rather, he talks to me that way all the time, but I need him. And so what we deal with that, are you causing more harm by getting the caregiver out of the house? And then that caregiver is the only thing between a nursing home or their home. So in this particular situation, you have to get the PCP involved. If there's a PCP, you have to start having those discussions. You have to attempt to get this help for this caregiver, get provider services in, give them ability for respite. But there are some deep-seated dynamics and systems that adult protective services alone wouldn't be able to untangle and unravel. The benefit of living in this community, San Antonio, is that there are a multitude of resources. Getting them connected to resources is, kind of where the rub is. But you have to look at the unintended consequences of our involvement and ensure that we're not, making things worse. And where the client is coming from. And oftentimes APS will go knock on the door and they will say, I'm used to it. It doesn't bother me. It may bother everybody else, but she, what is my lifeline? And I want no services. Don't come back and visit because your visit just makes them matter. So there are a lot of ethical dilemmas in those particular cases.
And I just want to highlight the need for respite services is so really so very high. I think we can do all things, but we do need rest in between. And I've been in caregiver and carer focus groups where you can see both sides. The person receiving the care and the caregiver are literally in crisis because we can do all things, but we need a little bit of rest. We need that little respite. We need to step away. We need to recharge our batteries. And there just isn't enough respite care in our spaces, in our community.
Okay, we are going to go ahead and do case scenario number 4. Sherry is hospitalized with a minor GI bleed. You are her medical POA. The doctor recommends a blood transfusion, and then she can just be on her way home. Sherry was raised with religious beliefs that do not allow her to have transfusions, but you do not hold those same beliefs. So what do you do? Do you override her wishes? What if she has not been active in her religious practices for some time? We're going to go ahead and assume her medical POA has been activated, right? That she has been declared incapacitated. So what do you do? Anyone, go for it. Myra, our medical ethicist over here.
So I think, again, coming from my perspective as an anthropologist, religious beliefs, especially those around medical care, they're not just rules, they're really part of someone's identity and their worldview. And it could very well be tied to her sense of self and control over her own body, right? Her bodily autonomy. So even if Sherry hasn't practiced in a while, that doesn't mean that her beliefs don't matter anymore. So the first step would be, which you already said, did she communicate these clearly, written or verbal otherwise? If her refusal was clear, then I would feel ethically bound to respect her wishes, even if I personally disagree with them. However, if there was a case where there was more ambiguity, then, that might be the point where you need to involve the medical team, or if there's like a hospital, ethics consultant. But otherwise, it's really up to you as the POA to remember that you're there to honor that person's wishes there and value what it is that they said and their desires, because that's really the core of like compassionate and culturally informed caregiving, that to respect their wishes and do what you can to support them.
Almost feel like mic drop on that one, right?
When you do a medical MPOA from an APS perspective, we always ask, does one exist? And we have our in-house attorney in the back, and so we send it to the our in-house attorney to review it and make sure that we are adhering to that legal document. My only recommendation from an APS perspective is there are 2 players in a medical power of attorney or, those types of documents, you and your medical power of attorney. And so I want to make sure that I have a conversation with the person that I've selected to be my medical power of attorney and be very clear about what my wishes are. And I happen to be medical power of attorney for people, my family anyway. And before I sign there, I make sure that my role is to have a discussion with them and say, tell me what it is that you want so that, we don't have any other issues. So all of that pre-work that I've been talking about that people should be having, that needs to be done so that when we are faced in these dilemmas, our legal recommendation from our attorney, the APS attorney, is going to say, you follow what those legal documents tell you to follow, whether it's a medical power of attorney, a statutory, the fiduciary responsibility, whatever that is. So if you are a caregiver, if you are a professional and you're dealing with elder individuals, that discussion you should be having with them is make sure you know who you're selecting and make sure you tell them exactly what you want.
And I think,
Because-
yeah, I was just gonna interject there. About 25 years ago, 30 years ago, there was a study done by, I think it was the Hartford and AARP, And they got a group of people who said, yes, I've talked to my MPOA, my son, my daughter, whoever. And then they talked to the person and they agreed, yes, my mother, father, my loved one talked to me. We talked about what they want. The elder person said, yes, we talked about what I want. And then they asked them a series of questions. What did you tell your kid? Or MPOA, and then they asked the MPOA. It was an 80% mismatch. So even people who thought they had talked to their MPOA and the MPOA thought they had been talked to, it was messed up. And I think that's where we'll come back to. That's where the 5 wishes, the conversation project, all of those things help people to have those discussions.
Also, we're thinking that Sherry doesn't want this blood transfusion, right? But I would be talking to the medical people and saying, what are my alternatives? Get in the medical team. Remember, this cannot be an isolated thing. If you know Sherry, because we've got to go with her wishes. So what other things can we do other than a blood transfusion?
I loved all their answers. There were a lot of what I was thinking. It's great. I agree with Jane. And, if I find myself in an ideal scenario, this is a conversation that's had before the power of attorney signed or at the time of signing so that you are apprised of their wishes should anything happen. But I don't think that's always how it happens. And sometimes you do find yourself in a position where you are anointed, right? It's like a last case scenario. Somebody's getting sick, they're degenerating, they got to figure out something fast. So in a situation like that, I think what I'd first try and do is check out their medical history, because perhaps this is something that's been noted previously in encounters with the doctors. Have they made anything known prior? Is this in their records? Are there any advanced directives or anything like that? And then their close community. So, do they go to church? If it's been a long time, where is it? What are their beliefs? Who's a friend from their church or a friend of theirs? Has any of this been communicated? If I'm trying to fill the holes in that ambiguity, but I agree with what the other panelists have said. If I have the indication, and it's a pretty clear one, that they have a preference, then I would probably honor that preference. I do think this does become an ethical question, but yeah, my preference would be to make that deference if it's clear that that's what they want.
I love the idea of going, I think both of you, addressed that, was dig deeper, right? Go to a pastor from that religion, go to friends. Yeah. And anyway, great. Okay. Well, that concludes our ethical scenarios. So hopefully we gave you all lots of things to think about. Where there's only a little bit of time standing between you and lunch, which I'm not sure is here yet. So we're still waiting on that, but let me introduce real quickly. First of all, let's have a round of applause for our wonderful panelists. And I don't know if they already did this, but I love APS. So has everyone from APS been acknowledged today? If you're from APS, could you stand up in the room? Yeah. Thank you guys for the work you do. We really appreciate you. Okay, well, with that, I am going to introduce our community spotlight. So I'm going to introduce, yeah. Oh, some people clapped online. So even the bots love APS. Okay, well, with that, Alice Alvarez with the Housing Content Manager, Facilitator, Community Engagement Specialist from Sacred is going to talk to us about the wonderful resource of Sacred.
Thank you. Wow, it's a great place to be between you and your lunch. So I'm going to try to make this as interesting as possible. On your device, whether that be your phone or your laptop, please search for Sacred, SACRD, if you're not familiar. It stands for the San Antonio Community Resource Directory, SACRD. It sounds like we spelled sacred wrong, which we didn't. But anyway, if you're not familiar with Sacred, I'm gonna give you a real quick overview. They're gonna give me a thumbs up when lunch is here and I'm gonna get out of your way. So Sacred has been around since 2019. It started with the city of San Antonio. They are still the primary funder. And it started with about 2,000 different resources in and around Bexar County. So it's the greater Bexar area. Now we have almost 12,000 resources on Sacred. So you can find everything from the womb to the tomb. And just, you name it, it's in there. And if it's not, we want to know about it. At the very top of the website, you'll notice, or on your phone, you've got to click the three little lines. You'll notice it says, what are we missing? So please search for your program. If you're not in there, click on what are we missing, fill out the form, put in the primary contact, and you can put your different programs in there for free. Sacred is anonymous and free to use. When you find a resource, you need to go to them and find out what it is that they require. You can look at their website through Sacred. You can share through Sacred. You can do all kinds of wonderful things to share these resources. There are QR codes for every single one of the resources. So that is what are we missing. Then I'm trying to imagine the website in my brain. Also on that homepage, you can find me under training. My email is there, and you can sign up for the online information sessions. If you have new staff or staff that is like, Ali, I don't know where to find all these resources, please, please join the training so you can see that very simply. We update the resources a minimum of once a year. At the bottom, right now we're about every 8 months we're updating them. At the very bottom of every resource, you'll see when it was last updated and a nice little spot where it says update suggestion or suggestion up. I don't know. I'm not eating lunch either. My brain is just like y'all's. And the brain can only take in as much as the butt can withstand. So these cushioned seats work really well. Okay, I'm trying to wake y'all up. So at the bottom of that, you'll see a suggestion update. So anybody can put in for a new program, anybody can suggest an update. So if you're familiar or you've been calling or you drove by and right now a lot of changes are happening. So if that has happened and you know something changed with that organization, please, please let us know because that'll move that up to the top of the list. We also have the categories. You'll see all the categories. You can just go down each one of them, everything from volunteering to hearing or visual, vision glasses and things like that, dental, just overall health. And then we have our, okay. The overall health and housing and paying your bills, all of that. Then right under that, you'll see the little squares. Those are our portals. We are right now actively creating a older adult portal. Some of y'all may have joined some of our listening sessions, and we greatly appreciate all of the help that y'all gave on that. So the older adult portal will work just like the other portals. You'll click on it. It'll start asking you some questions, a zip code, so that you can find the resources closest to where you need them. And then all of that other stuff. The mental health portal right now has, and will always have, the main phone numbers. So you can click on those. You can share the entire portal with people, or you can share specific resources. It's all set up the same. In the portals, you're always going to have your filters on the left because sometimes you'll be in there and it's 275 suggestions. Well, if I'm in the mental health, well, if I'm in any of those portals and it says 275, that's too much homework for me. I'm gonna have a royal headache and probably a panic attack. So I'm gonna go through those filters and try to filter that down and get that number a little bit lower. Or I can go to the opposite side and just start scrolling. See what looks good. Oh, look, there's something at ACOG. I know them. And click on that and find out how to get in touch with them. You'll always see the map. The map you can interact with as well. It'll go to Google Maps. And so you can see where this is located and if it's close to you. Please join the trainings. We have those, they last about 45 minutes. And I'm not getting a thumbs up yet on lunch. Should I continue to entertain? Okay. We're going to release them anyway. That way you can do all that pre-lunch stuff. Any major questions? They're like, really, Alice? We want lunch. Y'all know where to find me. I'm in the other room. Please come by, pick up a card, and let me know if Sacred can support your organization in any way. Other than funding, we don't have any. Okay, thank you guys. Take care.
Thank you. I was going to say, getting the word out about a lot of these, that's worth, well, I'm going to say worth more than funding, and I'm going to get stoned, but all right. Well, I'm going to release you guys. We will come back here at 12:45 to talk about solo aging. Let me really quickly talk about CEUs, unless you have something. Okay, so lunch is on the way, so we're going to let you guys go talk to vendors. But CEUs, if you're getting CEUs, make sure you signed in. I know sometimes a few folks came in late and may not have actually checked in. We need to know that you were here. So if whether you're CEUs or not, make sure that you check in. And if you are here for CEUs, as long as you checked in, or if you're online and you checked in, we'll be sending those out by email, the CEU certificate. So with that, I release you. Go visit with some of the vendors for a few minutes, go take a comfort break, and lunch should be here in any minute. Good morning. Good afternoon. How's the lunch? I know, right? Thank you to, oh my gosh, who ordered the lunch? Because this was Lisa, I don't know. Paula, all right, Paula Riggs, right there. She's standing right there. Okay, and a trick that she did, she ordered extra meat on every sandwich. Another round of applause for Paula. That was fantastic. All right, well, welcome back, and thank you guys for going with the flow. So I get the honor of introducing our next speaker, who's going to talk about solo aging. So Joanne Tobias Molina, I can't believe I need to read this. I've known you for about 722 years. Speak from the heart. Oh, you don't want to know what I'd say about you from the heart. Okay, Joanne Tobias Molina is the Salsa Project Coordinator for San Antonio Area Foundation. She completed a Master's of Arts degree from the University of Incarnate Word and has over 30 years of experience in the social services field. In addition, Joanne currently serves as the District 1 appointee to the Joint City-County Commission on Elderly Affairs and is an appointee to the American Society on Aging Economic Security Advisory Council. And it doesn't say here, I mean, you've worked with ACOG, you worked with APS, you worked with everybody. Moses knew her. It was fantastic. Joanne enjoys spending time with her pets, her family, and cheering on the San Antonio Spurs. Go Spurs, go. All right, so with that, we'll hand it over to Joanne.
Back there. I sat back there earlier and I said, just how far back does this go? And I sat back behind Jesse and I'm looking back there and I'm like, wow. And then I was reminded, you need to stay here in the front. You can't move because there's people online. I'm like, but what about those people back there? So thank you, Byron, for that beautiful introduction that I wrote myself, straight from the heart, totally. He said that even Moses knew me, and I think that's kind of an ageist statement. You know what? I think I'm going to report him to Jane. Oh, back over here. Good afternoon. I have no problem with everybody eating and continuing to enjoy your lunch and relax. That keeps y'all going, and maybe you won't really pay attention to what I have to say. So that's better, okay? So good afternoon, everyone. I'm hearing some feedback, so if I start like freaking out a little bit, you know, it's because of this. But here comes the man of the hour. Thank you, sir. I appreciate that. Even if I do, it still might be the voice in my head, but that's all right. So, yes, truth be told, I did work for Adult Protective. I was talking to Ms. Cortez here. She said she started and had 37 years of service. And little known fact, she and I were in basic skills training together back in 1990. We used to call her my little sister, you know, but I had the smarts to get out a while back. No, I'm just kidding. I told her that Governor Abbott wanted her to retire because, y'all, she's been in like 100% of her pension already. So, but I retired 10 years ago and I had the privilege of working here at ACOG, and I went to work at the city for a little while, and I made my way to SALSA, which is a part of the San Antonio Area Foundation. And so that's me. I used a nice picture when I was a few years and pounds ago. So what is SALSA? SALSA is Successfully Aging and Living in San Antonio. It's a community collective impact part of the San Antonio Area Foundation. And we are your community partner. We are a community foundation. We've been in business 60 years now. Part of how you know us and you love us is related to Santico's entertainment. So every time you go to the movies, to Santico's movies, okay, and you buy a ticket, you buy popcorn, you buy a soda, you're helping the community. Mr. John L. Santikos left his legacy gift to the Area Foundation to manage, and we do that by several ways. One is in scholarships, one is in grants to community foundation, community organizations. So that is how you help contribute when you go to the movies and you help Santikos. Santikos helps then in the community. So we're very excited to be here. Thank you to Lisa and the board for inviting us today. So I'm going to be talking about solo aging. And I know all of you have had quite a busy day already. So hopefully this topic will be something that you can walk away with one or two things that you really want to take back and think about. And I'm going to start off by thinking about our definition. So what is a solo ager? We're going to talk about planning, and then we're going to talk about resources. So first things first, what comes to mind when you think about a solo ager? You can just yell out at. Aging by themselves, okay? Somebody else. Independent. Isolated. Loneliness, okay? Heard that a couple times. Mostly women. Somebody else, or you're still busy chewing? I'm sorry? Happiness. Okay, a caregiver, or possibly even living there. Lots of different things, right? Thinking about solo agers. One of the things that I will hopefully think about today, and this, some people take this very differently, and some it's not intended in a bad way, but I have news for you. All of us are aging. I know. Imagine that. Sometimes when I say it, not to audiences like you, to other people, they're like, I don't want to talk about being old. I'm serious. Y'all are professionals. No, you're good. But sometimes when we talk to people, they'll be like, I don't want to talk about that. I'm not aging. I'm doing everything I can to not age. I'm like, guess what? We're born aging. Everyone's aging. And all of us are aging in our own way. And in many ways, many of us are solo agers because no matter what the journey, whether you have a partner or a friend, you're married, your aging journey is your own. It's your own body, your own history. How are you going forward? So here's the definition of what is a solo ager. So as you can see, I love this lady's picture, right? She's independent. She's talking about solo aging. Basically, individuals who may be living on their own terms. I like that. I like it. Think aging on my own terms, living on my own terms. Somebody mentioned being independent, right? Maybe they've always been on their own terms, right? Living independently, able to handle, take care of their own affairs. So this is what is a solo ager. Now look, this is the other part that sometimes props, glasses. So they live alone or expect to live alone at some point, or they maybe have limited number of family members or friends or social contacts in their area. Let's talk a little bit more about the soloness. So what does it mean to be a solo ager? We're going to talk about some demographics. To start out with, some solo agers may not have children, or perhaps the children may have a disability and is not able to provide some kind of care or have an arrangement with that person. They may not have a partner or a spouse, or maybe their friend or partner is the same age as they are, and they're on their aging journey together. Or you maybe not have any living relatives with you where you are, or maybe your friends as you've gone forward. So we're talking about demographics. Who's the actual solo ager? The relational piece, some of this is, I think, kind of straightforward for us. Those of us that have been in casework for many years or working in the field now, you can see, you've seen all kinds of different families, right? So we have people who live alone. Maybe their children or their family members live a great distance away. Maybe their friends or families are just unreliable. They're not individuals that you would want to be involved in your care. I like this one, the dysfunctional functional family, right? Sometimes I used to say we put the fun in dysfunctional, right? Because you just see some cases where we understand why they may not want to have a relationship. Earlier, Byron talked about that, where they may not have been the best caregiver or the best parent growing up. So there's a reason why they don't have a good relationship with each other. They may simply be just estranged from their family for whatever reasons. Under the behavioral side, this one I take a little bit, I'm still studying this through. It's the one talking about extreme independence or being very reclusive. And some of us, the way we brought up, we may be just very independent, you know? We like to do our own thing, go about our own business. We take care of ourselves and we don't bother anybody. And we're just very independent. And we kind of have this idea that we don't need anybody, right? If we find somebody, great. If we don't, it's okay. We're moving on. I don't like this next one. And I said, the lack of social and or self-management skills. I said, now what does that mean? And I started thinking, well, possibly it could be that someone, as we're growing older and getting in, in our set in our ways, in this individual case, where someone may have the lack of social skills to maybe just doesn't go out, doesn't socialize, doesn't have any, any desire to be involved with the community or out in the world. And so they have decided to be kind of reclusive. I think we know people like that. Maybe they're just very happy with their own company and they don't feel like they need to go out. Maybe they're an introvert. They've always been an introvert. And now they just decided this is best. I don't have to leave my house. Do you ever hear anybody say that? That I don't have to leave. I can get everything delivered. I can watch everything. I don't have to go to the movies when they tell me. I tell them, go to Santikos. No, why? I can just stream everything. I can get Amazon delivered everything. I never have to leave my house. Wow, okay. For some of us, that's just blowing our mind. Like, wow, how could you not leave your house? Well, very simple sometimes. Think back to the pandemic when we couldn't leave our house, right? And so much of this thing of the solo aging started really during pandemic times where we were thinking about different ways that we had to live our life. When you needed to think about, how do I get my groceries, my pharmacy? What do I do? I can get this delivered. Well, for some of us, it's been a downhill battle since then because my husband and DoorDash are like partners. They're like this, and I think they call him just to make sure, like, are you okay? You haven't ordered today. It's like, tell me about it. I'm like, yeah, some people take it to an extreme. However, there's personality disorders and thinking about that. Well, and I think we can understand that if you have an illness that perhaps makes you unable or unwilling, or perhaps it's just not an area that you want to be out and about talking with people, makes you uncomfortable. You feel like I really just want to be on my own. You can see why someone might decide to be a solo ager. There's the substance abuse, and we can talk about that. Maybe the cases you were talking about earlier today, where we talk about maybe alcoholism or other substance abuse, talking about why someone may decide to be a solo ager, or this is how they became a solo ager. Past trauma. Let's not talk, we don't have enough time to talk about trauma, but we all know that trauma plays a factor in our aging experience, right? Some of us are luckier than others, perhaps because of experiences they've gone through. Some of us may not score very high on the ACEs exam, adverse childhood, ACEs, E and S, you know what it means, on the ACEs test. But some of our older adults, our clients, some people we're working with may have had quite a bit of trauma in their past. And so they have decided that, I'm just not an individual who's going to go out and trust individuals very carefully or very, easily. It's just not my style. It's not what I do. Then there's the other, it's where the solo lives. So it depends, on where we live. If we live in a very isolated area, there may not be any friends or family around us. Maybe we're living in a ranch somewhere down deep South Texas and we're just isolated. And that's just where we've lived and grown up. And there's just not really a big social scene there. Um, there's a homelessness issue. Why do people become homeless? That's a whole nother subject. But this is the areas of who is solo, who is a solo individual. So we may have heard this multiple times today, but the US Census estimates that by the year 2034, people over the age of 65 will outnumber children in population size. By 2060, I heard a wow over here, all right. By 2060, nearly 1 in 4 Americans will be over the age of 65. And the number of 85 plus people will triple. And then we're going to be adding 500,000 centenarians. It's amazing. When you look at the data now, children born in the year 2025 have almost a 50% rate of making it to the age 100. That's fascinating to me. It's like, how did that happen? How lucky we are to be living in this time, to be able to have those advantages. That also has an impact on us as we're talking about this whole demographic of solo agers, of who are the solo agers. So according to the census, 26% of those born between 1946 and 1964, who are considered to be the baby boomers generally, were either widowed, divorced, separated, and another 9% of them had never married. In 2021, the same census data reported that 15.2 million, nearly 1 in 6, or 16.5% of adults age 55 and older are childless, or as I like to say, child-free. I am child-free. And the levels of child freeness, I should have changed that, childlessness among older adults is expected to increase. Why is that? I think what we know is that the birth rate in the United States is declining, right? Most of the birth rate going up in the United States has been attributed to immigration, the rates going up. So we know that there are more people in the United States that are having fewer children. They're expensive. No, there's approximately 22.1 million solo agers in America. Did you know that there was that many of us? Is it something new? Had you thought about solo aging? Is this new to anybody? Yes, everybody's raising their hand. That's why Lisa had me come and talk about it. One of the terms that they used about solo aging prior to the pandemic was a term that I really despise. They called them elder orphans. I know, boo, hiss. Who thought up with that? When you go back tonight and you decide, or maybe even right now, when you're like bored, not right now, but in a minute, you can look it up and think about the terminology and put in there elder orphans, and you'll see a whole body of knowledge. And say, well, no, that's got to change. So now we're using the term solo aging. We're using other terms. We're saying aging on our own, aging our way. Other terms, kind of something, we need something snazzy. Not that elder orphans. I don't like that. So what are we going to talk about today? We've kind of defined what the role of is, or the definition of being a solo ager, someone who's aging on their own terms. They may not have the traditional support system that we think about, family members. They may not have a partner, or maybe their partner is their same age and growing old together, or maybe because of death, accidents, something else, serious illness, the person is really on their own aging journey. So now you're going to be thinking, wow, that might be me. Say, well, what do I need to get started? The good news is that it's never too early and it's never too late. You're also not alone. Now we're going to talk about a favorite subject of mine. Not really, because I am not a good planner. Everybody in here has a different way of the way their brain works. Some of us are planners down to the nth degree. Some of you knew last night what you were going to wear. You ironed it, you set it out on the bed, you knew exactly how long it was going to take you, and you planned to get everything settled, and you got here early, and you knew exactly where you were going to sit, how long it was going to take me to get here. And I know y'all are looking at each other like, yeah, I know that person. That's the planner. And then there's some of us who may have decided this morning, like, pick it up. Oh, it still smells okay. Let me just put that on. Nobody's going to notice. I'm sitting far away. You don't plan. That's just the way your brain works. It doesn't quite work that way. But and usually you're friends with each other, right? The planners and the non-planners. But why do we plan? Everybody plans every day. You plan all day long. What your day's going to be like, who you're going to go see, what you're going to do, how did you get here, where are you going to go after this, do I need to stop and get gas, do I have money? There's always something going on, right? But planning, when you think about planning as a profession and thinking about being any urban planners here or people who are really into planning, I love those people. But man, they can get on my nerves. Because my husband is a planner. And he'll plan a vacation down to the nth degree, Like we're gonna get up at 7 o'clock, we're gonna do, and it's like, oh, that's not for me. But when you plan, there's a reason to plan, because then you set clear goals and objectives. You are able to make better informed decisions about whatever it is that you're working on. You can identify whatever obstacles you might have and whatever trials you have. You're gonna outline your steps to achieve these goals. But all planning also ensures adaptability and flexibility. Like if the lunch is late or the speakers go long, right? Everybody has to plan. My favorite subject, steps of strategic planning. Now look at this and you're thinking, oh, she's really gone off the rails. How does this have to do with solo aging? We're talking about doing a needs assessment about ourselves. Ooh, you didn't think you were gonna have to do some self-awareness, right? Self-awareness, we're doing some self-awareness about ourselves. What is our own needs assessment? If I said at the beginning already that each of us are aging, right? We're all aging. And most of us, almost all of us, are on our own solo aging journey. Whether you have a husband, a wife, a partner, doesn't matter. You're still in your own solo aging journey. your body, your health, what you want to do, your legacy. So you were all really solo agers in this together. So you really have to do a needs assessment. And some of it is going to be like, and big time, like say all of a sudden your birthday's coming up, you're going to hit a milestone birthday, maybe retirement's coming up, you're starting to think about that. Or maybe you had a rough day on the job and you say, I just don't want to work here anymore. Do I have enough money to quit? I know some of you think about that all the time. That's my needs assessment. It's like, well, what do I need? Do you ever see, I know most of y'all probably stream your TV so you don't have to watch commercials, but I watch commercials. And they do these commercials about, well, if I want to live, like go on cruises 3 times a year, what do I have to do that, right? What do I need to do with my finances to get there? So you have to do a needs assessment. You have to prioritize. You have to set your own goals, develop my formula to make me get to my goals, and then we implement our plan. The good thing is we're always able to update, revise, review. We're always able to change our plans, and that's why we pivot. So what is it in my plan? What do I have to do? So this is where you're thinking about myself. And you're sitting here thinking like, I had a good lunch. I could use a little nap. I'm a little tired. Maybe, oh, I'm doing so good. I'm so glad I got to be here today. There's a lot of things going on in your brain. You're thinking about your caseload. You're thinking about what's left. You're trying not to look at your phone. I realize that. But what can you control in your plan? This is a beautiful image. Part of it is like, I have to remember myself. There's a lot of things that we cannot control, right? I know sometimes y'all feel like you kind of be in control. Everyone's different, but like, wow, I really wish I could have control over all of this. There's only certain things that we have control over, right? The circle of control, what is it that I can control? I can control my own health habits. I can control my own financial planning, my money management, my size and scope of my social network. What kind of social network do I have? A support system. Have I done any advanced care planning? And where do I live? Those are some things that are in my control. Other things are outside of my control. What the stock market is doing, what's happening outside in the world, all these other things outside of my control, right? So what we're going to think about and focus on for the rest of my time, and somebody's going to have to remember when it's time for me to wrap it up, because y'all know I like to talk. We're going to talk about our plan. So what can I control, okay? I can control where I live, who helps me, and who provides my companionship. Okay, let's talk about where you live. Thinking about where you live now, newsflash, that is not a newsflash for anybody who works with older adults. Most older adults want to stay in their own home, right? Unless, of course, they win the lottery and they want to move to a mansion or they want to do something else. You know, you never know. But for the majority of individuals, every study that we've done the research on, everyone wants to stay in their own home for as long as possible, for as long as it's safe to do so. So what does that mean? That means we all basically want to age in place. So what does it mean to age in place? Well, we need to assess whether our neighborhood or community meets our needs. Is this where I want to stay? How many of you ever, and you don't have to raise your hand, but just think about it. How many of you ever thought, well, you know what? I'm just done with San Antonio. I want to pick up and leave. And then you start looking, well, how much does it cost to live in Austin? Well, how much is the rent there? What about Houston? Well, maybe I need to go down to Catula or down to Atascosa. Maybe I can afford that, based on my salary. But you think about it, say, well, is this really where I want to stay? I think about it every now and then when something bad in my neighborhood happens and I'm like, I'm done with this. I'm like, well, no, I know I'm not done with it. I've invested 30 years in this house. I'm not moving. I'm being realistic. But is that house going to suit me? 10 years ago, when I retired from the department, my husband was in the hospital because he'd had an accident and he was having to relearn how to walk. He was actually in the hospital and then going into a rehab center afterwards. And so that was a big aha moment for us because our house is old and it has these huge stairs. And we had to figure out how are we going to bring him home? How am I going to bring him home from the rehab unit if I can't even get up these stairs and get to the bathroom door wider and get to the bathroom? How am I going to do all of this? And these are the kind of things that, did I expect that to happen, an accident to happen? No way. No, we're having a fine time. Didn't expect that to happen. So it's kind of like we never know what might happen in our lives, right? We're all temporarily able. Anything could happen to change it. We might change our job, might have an accident, might have a new job somewhere else. So you start thinking about your neighborhood and your community and think about, like, is this where I want to stay? Do I have nice neighbors? Good neighbors? Do I know my neighbors? Do I do I have a bad neighbor? Is this something where I want to remain here? What about the accessibility? Just like I was mentioning with my husband and how we had to readjust our lives around the house and figure out a better way to live in that house. We couldn't afford to just up and move. Who can? Nobody really. Not in this room, unless you're wealthy, I'm not sure. But thinking about what other services and support is there that I can utilize to be able to help me stay in my own home. So where you live, thinking about that. My accessibility, my services to support my aging in place. And Sarah Davis over here, who'll speak after me, has a whole presentation on aging in place, all the different things that you can do to help plan ahead. So who helps you? Now, this is the biggest issue, I think, in my research and talking about solo aging is who helps me? Who's going to be my person? And I've thought about it. I'm child free, okay? It sounds like pest free, right? Or something. I love children, but no, I'm child free. So I think about this. It's like, who's going to help me with my financial decision making? Which one of my nieces and nephews do I trust enough to make the right decisions for me? Hmm? You're starting to ask yourself, like, well, yes. If you can think about this today, I know you've got a lot on your plate today, but think about this. Who is going to be my go to person? Who's going to be my go to person if I need to make decisions about my financial decision making, my power of attorney, my money management? Who's going to take me to the doctor if I can't drive myself? Most of us in this room are probably the caregivers, the fixers, the ones that other people rely on, right? So think about yourself. Think about this whole solo aging piece as a way of investing in yourself, doing that needs assessment. What do I need to be able to maintain myself and my aging well so that I can move forward and be as comfortable as I can as I'm aging? And remember, we're all aging. Who's going to help me with my healthcare directives? Now, look, it can be overwhelming at first. And I'll tell you this, you have to take small steps. My aha moment should have been when my husband had his accident. I think I would have learned my lesson. But when I turned 60 this past year, I was like, oh my God, I'm 60. I'm eligible for services. Yeah, right. But now, I got to get my act together. It's like when you start realizing, like, wow, I have less ahead of me than I have behind me. Ooh, it can blow your mind. You can get depressed, overwhelmed, and thinking, oh, I'm done with this. Now, unless you're one of those planners and you already had all this worked out. I don't know who those people are, but I like them. All right, so what do I need? I need a will. Everybody in here needs a will. I know some of you are looking at me like, I don't have anything. Do you have a dog or a cat? I'm like, oh, well, yeah, I do have a dog or a cat. Maybe I have both. Well, what's going to happen to to the pet? Everybody needs a will. I know you don't feel like you do. I'm too young to be thinking about this. Oh, I wish I could have my lunch outside. But there's a lot to be thinking about. A will, a durable power of attorney. I need to complete paperwork with my bank. You think that it's all simple once you do your will and your power of attorney? No, you've got to go to every single bank that you deal business with and fill out forms, more forms, forms upon forms to make sure that the right person is going to get your beneficiary, that they are your beneficiary and they're going to get the resources that you had for them. I started doing this 3 months ago. I went through, made a list, identified my bank accounts, my credit cards, and putting an Excel spreadsheet together. And I was very proud of myself because that is not my forte. It is not. And then I told my husband, and he's a little older than me, not much, but he's older. He has some health problems. It's even though we're married, we're child free. So what's going to happen? What are our plans? I said, I'm going to make a list of my passwords. I'm going to make a list of everything that I have so that you can access it in the event that something happens to me. And you think about it like, well, how many of us in this room have actually sat down and gone through that for ourselves and done a needs assessment? What is it do I need to ensure that somebody else knows what to do in case of an emergency? Now, how much time do I have left? As much as I want. 20 minutes, super. All right. So, what do I need to do? Are y'all depressed? Are you sad? Don't be. Don't be. Because we're living on terms on it's our terms. It's our way. It's our way of living. We want to move forward. We want to be able to have comfort in knowing that our plan is taken care of. Here are all the things that I want you to think about to do. Not today necessarily, go home and think about it, but I do want you to start thinking about this. Who's my healthcare power of attorney? My living will, updated list of my current health problems, my medication and dosages, names of my doctors. Do your people know who your doctors are? Your people. What does that mean? Well, my neighbor, my friend, who is going to take care of that for me? You know, do I have a list of things to think about? Who should I talk to this about? The good thing is the great state of Texas has a lot of resources for us. And I believe you'll be able to get this sent to you or as part of the presentation. There are a number of legal and medical resources. All of these on this document here, they're free. It's all free to access. You can go online and you can download your surrogate decision maker. You can get your power of attorney. You can even get a free will. If you go to our website at the foundation, that's not a plug. Anybody, that's the only one. There's a lot of them that you can do, but you can start a will for free. You can do that online. You can lay out the information that you want. It's a way to get started with the conversation. So I should have said at the beginning, I'm not an attorney. You know I'm not an attorney. Seek legal counsel if you have specific questions about any of those documents that are on there. But it is available for you to utilize and not only share with your friends, your family, your coworkers, but also think about, how am I going to implement this with people that I come across in my work? So let's talk about the companionship part. That's not more fun, right? Nobody wants to talk about, like, did our attorneys leave already? No. Some of our attorneys, one attorney. It's a lot of work. It takes a lot of work to think about your will and your power of attorney and all the things that you need to do. And that's why there are attorneys available for resources and information. All right, so let's talk about being our companionship. Now, some of us, like we talked about before, how our brains are different. Some of us like to be extroverts out there talking to everyone and everything. Some of us more introverted. So some of us may not have a big network of friends. Some of us, our friendships ended when we retired, or maybe we moved on, or maybe in the divorce, he got the friends and I didn't, It could be a lot of different reasons why our companionship areas have changed, right? So let's think about what are we going to do to set out new friends? Those of you who do have small children or children, sometimes you make friends through them, right? Most of the people you know are like, we're on the baseball team with them, went to school with them, and you kind of have a way of like, that's how you meet new friends. You're so-and-so's parent. Oh, okay. When you get older, it's a lot easier, it's a lot harder to make friends sometimes. And sometimes if you don't like people, well, then it's really hard to make friends. So what do we do to make friends? How do we go about making new friendships? Well, one of the things that we want to promote is volunteerism. Volunteering is an opportunity to meet new people, to explore the things that you like to do, and to be able to be out there and keep active and keep engaged and thinking, not only keeping your brain active, your body active, but actually trying to help yourself make new friends and be able to engage in some activities that add joy to your life. I like that one. It says, live your life, and thinking about what brings you joy. What are some things that you like to do outside of work? Because sometimes what we end up doing, all of you in here that are workers and caregivers, and you've been maybe a social worker your whole life, you give all the time. You're always giving. You're a caregiver. You're always giving, and you find like that's all I do. My whole identity is wrapped up in my work and what I'm doing out there. Well, what you need to do is take some time to help yourself find new ways to find joy. Find a balance. You know how they talk about the work-life balance? It's true. And some of us kind of forget about that because we have different generational approaches to work. Some of us think work is everything. And I think that's what one of the newer generations is like, oh no, I'm going to fit work in wherever I can, right? My life comes first. And thinking about cultivating those relationships and those activities and things that you like to do, what brings you joy? One of the newest things that I think is very interesting and kind of like, I want to see where this is going. It's online solo aging organizations. I'm going to tell you about this. I joined a couple. So I went to my first one. It's sponsored through AARP. It's a solo aging support group. They meet twice a month. And these were people all over the country. Most of them were women, just like Sandy had said, mostly women. They were over the age of 60. There were a few men in there. And these were individuals that looked like just me. Like I could be right there. I was right in there with them. We were talking about the challenges of being a solo ager. One of the things they brought up, the first thing, the lady was saying, I think there's a hole in my roof because I'm seeing drips come down. I'm 75 years old. What am I going to do? How am I going to do that? How am I going to get somebody to fix that for me? And the caseworker and me started thinking, well, let me see this, this, and this. So there's opportunities for her to share how she was feeling, right? Let her voice be heard. Other people came in, gave her referrals, resources, gave them feedback on what happened to her. How did she do it? This is what I did. And then some man, it had to be a man, sorry, that's a sexist comment, said, this is boring, let's move on. And I'm like, no, he didn't. I see that doesn't change. No, just kidding, once again. But I said, well, so the person, when he said, this is boring, let's move on, I was like, he said, well, they said, well, what is your challenge? What is your issue? And then he went off into a whole nother thing. So, you know, it's interesting. I'm not sure. I'm going to keep it going. I'm going to keep it going because I want to see how it works and I want to see how it moves on. But it's just one group. There's another group that's starting that I signed up for. The wait list is already like, 100 people long. But it's again, it's an online group because people who are maybe isolated, who don't have access to friends or family nearby, or maybe don't want to share those issues with their friend or their family or their neighbors. Maybe they want to have somebody, a neutral party, be able to just to listen to them. It's a very effective tool, I think, and it's going to be interesting. It's new for people in my generation, perhaps, and others who aren't used to going online. Some of you may have grown up as digital natives and are used to online gaming with people from all over the world, right? And it's not anything new. This is new for people of my generation and older who are thinking like, wow, I'm going to just get on there and just talk to people about my situation, about being a solo ager. What does it mean? What kind of resources do you have? How did you manage this? So, 2 more resources for you. Getting your affairs in order checklist from the National Institute on Aging. It provides you some opportunities to lay this out. How can I go through this? Where do I start? The other one is also from the NCIA, and you can order this online or you can even download it. It's Advanced Care Planning, publication, how to start that conversation. Because you're thinking to yourself, and I've said it to myself, well, now when am I going to approach my niece about this? In my head, it's all going to work out. Oh, she knows she's going to take care of everything for me. But does she really? Have I ever sat down with her and gone through this process? No, I haven't. I kind of mentioned it to her one day, and I said, you're going to be my power of attorney. And she was like, oh, okay. And probably thinking like, oh my God, what does that mean? Because they don't know what that means either. You think you may want to have somebody take care of that for you, but you're not sure until you have the conversation. And it's a tough conversation. So let's look at some of these plans to see how we can get started. What's the checklist? What's the jumping off point? Okay, I can't leave this conversation without having this bigger view about policy. So why do we need to think about solo agers in the bigger view and policy area and the broad view? Because the times, they're moving quickly. Life is moving fast, it's changing. Policy has not kept up. When you look at the Older Americans Act, which pretty much handles all of like Meals on Wheels, in-home services, all of the other things, the programs that we talk about, that has not been caught up. The definitions are not updated in years. We're talking about 20 years easy. So it doesn't reflect the changes in our world. It has this mindset, and the way it's written is that there will always be people there to take care of you, like a family member. That's how it's set up. So some of the things are not applicable if you don't have a family member living with you or able to do that for you. So we need to look at the broader perspective of having solo agers. And what does that look like in policy? One of the other pieces of this in policy, when you think about it in Texas, if you don't have a surrogate decision maker act in place, the doctors are going to go through the list of who's going to make decisions for you if in your healthcare if you're incapacitated and unable to do so. It'll start with the spouse, next to kin, siblings. It'll work its way down, right? At the end there of the list, if there's no one to make that decision for you, the doctor will make that decision, or perhaps the ethics committee at the hospital. And you think about that and say, well, anybody, well, maybe I didn't talk about this idea to someone who's in that position. But what if I want a friend to be my representative? Well, Texas law currently doesn't apply. It doesn't apply here. In some states, there are a caveat where friends are available and can be considered in the Surrogate Decision Maker Act. We're not there yet in Texas, but that's just an example of how the broader picture is in our world, thinking about how we can change the perspective of solo aging. Getting to the good stuff, right? Because wrapping up, resources and additional information. There are tons of resources out there about being a solo ager. Many people are making a great living promoting books and resources and conferences, and it's a whole growing field. If you haven't thought about it and you're thinking about, well, what am I going to do when I retire from the state? Or what am I going to do when I retire from wherever? Think about the solo aging field. It's packed full of opportunities to think about this. Think about how can I utilize the skills and talents that I have to helping others in my community. One of the things that we're hoping to do at the foundation, if you look at that last one, it says Aging Alone Together. They have a great program that we're hoping to bring to San Antonio. You can do it online now, and I signed up for it. It's going to start in July. And what they do is they walk you through a 6-week class where 1 week you talk about advanced directives, the next week you talk about power of attorneys, the next week you do financial planning, and you process that and go through it in a step-by-step way so that at the end of the time period, you have a plan in place. Here's some really great books and information about people that are excellent in their field. This Carol Merrick is actually coming to Texas for the Aging in Texas conference. And she has an online aging community, the solo agers as well. And she's very engaged and energetic. And she just started this field. And I believe she claims to have coined the phrase solo aging back in 2019. I've not verified that, but that's her claim to fame. More power to you. Make some money off of it, right? And I'm looking forward to meeting her. I've already reached out to her on LinkedIn and said, we'll chat next week and see how that looks like and see what does that look like about maybe having some online solo aging here in San Antonio. These other authors, also excellent speakers. And let me see, where's the other one? The summary. So everyone is on their own aging journey. Our aging is our own. See us there in the car seat? The car. Not in the car seat. What? Strike. We're in our driver's seat. I practiced that for a while and then it still didn't come out. We're in the driver's seat. It's never too early or too late to start planning. If you're over the age of 18, you need to think about giving yourself an opportunity to decide who's going to make the decisions for myself, should I become incapacitated. See that picture? That was me. I was like, oh man, this is overwhelming. What am I going to do? Where do I start? And I get myself all anxious and anxiety is going through me. Slow down. Take a deep breath. You can figure this out. There's a lot of guidelines available. Talk with your professionals and decide on what works for you. Maybe you can only do one thing. Maybe you only want to deal by getting all your insurance policies together, or figuring out all your finances, or figuring out how many credit cards you actually have and the balances and all of these things. It's like, well, that's a lot. I don't know if I want to go there. Start with one thing that you think you can take back and decide, okay, I'm going to work on power of attorney, or I'm going to work on the healthcare power of attorney, or I'm going to work on the financial pieces. Think about one thing that you can work on and decide this is how it's going to help me in my solo aging journey. Lastly, enjoy your life on your terms, right? That's what it's really all about. It goes by quicker than what we ever think it does. And we may not have had a plan that said, I'm going to be a solo ager, that I'm going to be on my own. It happened, it's happening. I can have control over how I live my life and how I can be an active, engaged older adult. And that's why I want to leave you with this, to think, live your life on your terms, but be smart and make those plans. And I think I'm right up against the end of the hour. And so I think that would be it for me. So now I'm going to turn it over to Sarah, who's going to be, or Byron, who's going to introduce Sarah. Okay, apparently I can introduce Sarah. I think we need a few minutes to switch sides, or maybe. But Sarah's going to talk about a resource that we have here in our community and is across the nation and available that's going to help.
Thank you, Joanne. All right, I'm Sarah Davis. I'm also in the salsa team, and just wanted to share an awesome resource that one of our impact areas is social connection. So we have a work group that was looking into researching how can technology help our older adults and stay connected, and we discovered this awesome app that we'll show to you on the screen in just a second. But this is a really cool tool, very simple, non-intrusive. It was designed and inspired by just recognizing that there's a gap in safety when no one notices when something goes wrong in your house. If you're living alone, this is an app designed for solo agers, but also for people who might have health conditions. They want to make sure that their pets are taken care of in an emergency, or they just don't have a strong local support system. So this is a daily check-in app. It's called Snug. And they've been around for about 10 years. And sorry that the yellow doesn't show up very much, but daily check-in app. And if you go to the next slide, it is easy to download, and you pick the time that you want to check in every day, and you just have to hit the big green button, and it'll give you a great quote for the day. We all downloaded it in our group to try it out, and you set a set of emergency contacts in there, your friend, your neighbor, whoever you want to designate. And if you do not check in that day at that time, it'll send a little message to your contacts that Sarah didn't check in today. Now, in addition, those emergency contacts, say your younger daughter lives out of state and mom didn't check in today. Well, you can set it up that every time she checks in, your emergency contact gets a message. Okay, so mom's up and about, good, she's there. So this is a peace of mind, very simple. Go to the next slide, and it's free to use for the basic plan, and it works, just as I explained. So just for iPhone and Android, and I know not all of your clients have the smartphone, but right now they are working on finding ways to make this adaptable on different devices like iPads and computers. But right now, this is what we have, and I think that's the basic thing. You do the free plan, or you can pay a monthly fee or a yearly fee, and there's a call center that will call in and check on you, and they can do wellness checks. So it's really cool, and we all downloaded it, and then somehow the CEO out in California said, "Hey, why are y'all doing the Snug app? And tell me how you think of it." So we're kind of like a test pilot city right now. And our usership here in San Antonio has gone up by 50% now. So we want to keep it going because I think it's really useful for people, not everyone, but like this demographic of solo agers. So that's my little plug. Thank y'all.
Thank you, Sarah. All right. And thank you, Joanne. She disappeared. She's behind me. Oh, I know. She scares the hell out of me. She's like a ninja. So I definitely, we do want to thank you, Joanne, for your presentation on solo agers. Give a round of applause for Joanne. Do it now. Thank you. And with that, we're actually a couple minutes early. So we'll give you guys a 15-minute kind of comfort break. And please, visit the resource room. Is that right? No, I think they're gone. Never mind. Well, you can still go down there and just hang out now. It's empty. But there might be a few folks still packing up, and then use the restroom, and we'll see you back here at 2:05. All right, how is everybody? We're in the home stretch, all right? And Daryl's promised to keep everybody awake after lunch. He swore, he said it's his duty. So I have the honor of introducing Daryl Greer. He's with Senior Planet's Older Adults and Technology, Ode Services. I was like, what's the S for? And just a phenomenal resource. So you guys are in for a real treat. He's going to talk to us about AI and disinformation. So here you go, Daryl.
Hello. How are y'all doing? Cool. Yeah. So right now, today, what we're going to just touch on a very high level, which is AI, right? What is AI? That is very superficial. AI, it is artificial intelligence. But really though, what is it? What does it look like? Right, right. Well, that's the digital representation of AI, but where is it housed? What are its components, right? Is it in some basement full of all types of supercomputers that's just chugging away, using so much different types of energy sources? You know, sounds like it's a computer, right? So then remember when you learned about computer programming, right? We learned about binary code. Who had experience? I always love it because we do our lectures with like older adults. So then you have people that talk about mainframe computers, right? And then they talk about how they would put the punch card into the device and then that would, right? All right, we got one there. And then no matter what, if you had to do a computation, you would put that code or that card in there and it was always the same. So let's say if it was 2 plus 2, that computer would be what? I mean, the solution would be what? 4, right? If you use the computer on your phone, the calculator, 2 plus 2 is equal to what? If you're in a submarine under the ocean, you type that in there, what's the solution? It's because the binary code in the program is what locked in the response to the computer, right? That code never deviates. The computer may fail operationally, physically, but the code, the programming is always the same. The way AI works is a different way of learning. It's called machine learning, in which it uses complicated algorithms, not binary code, but in a very flexible way to come to solutions, right? So then the way it's implemented is that if you were to put a code, you know, let's say like a prompt like cats, it uses the internet and this large base of information in order to come to an answer. Who's heard of the concept hallucination, AI hallucinations or digital hallucinations? This is kind of something that's really interesting is because AI, they call it a hallucination, but really it's an error. That means you put in a particular prompt and it doesn't come up with the exact answer. It may have, and this is what we're going to talk about is like AI and disinformation and kind of how to recognize those types of instances on seeing if something is AI or something is real. All right. So let's go ahead and get started. Rolanda, could you put on the video? What did I just see? We saw that guy. Who else with him? Paris Hilton. What are they doing? Nothing. Yeah, they're in a closet, right? They're about getting ready for something. Going to go skydiving. They're just being awesome. Isn't that real, right? Wouldn't you say that my eyes just showed me Paris Hilton and Tom Cruise, right? None of that is real.
right? And what's very impressive is the very fact that there was no cameraman who was moving around. There was no boom guy picking up the audio. That closet didn't exist. The coloring, the paint, the dress, and all that stuff didn't exist. It was as if we told somebody to imagine Tom Cruise and Paris Hilton together going to a whatever event and to create an image. But it was AI that we're watching. It's like we picked up its head and we're able to kind of see that particular type of prompt in action. And that's amazing. It's amazing to see this type of technology that's out there. And I believe, and as Oates, we're age reframers and technology enthusiasts. We believe that aging is positive, no matter how long we live. We're living longer through a longevity revolution, so let's use and connect with one another to make our time better. But we're also technology enthusiasts, in which we believe that technology is going to help us live longer and live more independently and autonomous. So then, yeah, what I'm going to do is go ahead and share my screen and start my presentation. Hold on. Uh-oh. Could you make me co-host? No, we'll see. Who uses AI in your work? Right? Quasi, look at my staff, of course you do. And it's because it is an amazing tool which can create so much efficiency just out of the freeing us from the manual or redundant type of, there we go, slides. All right. All right. Can you see my slides? All right. Here, let me try this. You can see them online, but not in person. All right, if Rolona, you're gonna have to run those. Okay, cool. Yeah, next slide. So then today what we're gonna do is a high level, just kind of discussion on AI and the help, what is that? AI and how it can help us and harm us. We're gonna talk about different types of information, disinformation, what's the difference, how and where you're most likely gonna be susceptible to disinformation or manipulation. We're gonna touch on deep fakes, tips for detecting AI-generated images, and also voice cloning and some best practices. Next slide. Oh, I have to do it? All right. My slide is frozen. Yeah. All right. Do you think you've seen content online? Raise your hand. All right. Yes, we all have, right? And then we've all talked about why. Why do you think AI and manipulation is such at a fever point right now? Why would the audience think? Nope. Fraud. When you look about it, there's over $3 billion was stolen from Americans in 2023. That number has grown last year, and it's going to grow even this year. It's because right now we're just inundated with information and so easily to get manipulated. When you think about the geopolitical world that we live in and how images literally are worth a million words, they can impact so many different types of relationships. Where do you think you're most likely to encounter disinformation? Online, right? Where online? Where are there any other pieces or any other places? Social media, Twitter, right? And if you look to see at different people's motivation or how they consume their media, it's fairly inexpensive to try and manipulate those folks if you're trying to use or if you have a nefarious agenda or anything else. Next slide. All right. The AI, hold on. Yeah. basically can quickly, the benefits of AI is that it uses its strength and its power to sort through so much information. AI is already here. It's in the back end of our Google searches. It's in our hospitals. It's in our banking institutions. In those areas, AI is used to help decipher information. It's able to spot fraud. It's able to help us kind of get to our sources a lot quicker and faster. Perfect. It helps law enforcement regarding the anti-fraud activities. Before that, you know, those types of links or calls, just to go through that amount of information would just take so much time. Interesting enough, AI can also help identify individuals. You go to HEB, you go to the airport, you see the monitors, and it's actually cueing into the precise measurements of our face to know whether or not who we are. Who feels comfortable with that? To me, I'm kind of like, I can go either way. It's unnerving to know that this amount of information is being saved regarding myself. So we have to, you know, I have trust in that how this information is being used. Also, it can set aside large patterns. So when I think about AI uses in hospitals and how there's so much information and samples that are being tested on blood or anything else, it can help in the diagnosis of different types of diseases where humans may have greater error of overseeing something. But then when it comes to the nefarious or the bad way AI is used, it's easily used to send misinformation, just on social media, which we all know that information and news coming from those sources are, you know, you can't really trust it. And what we do in our senior planet is that we tell individuals to rely on trusted resources, .govs, the agencies that you know, your news, ABC, Fox News, well, not so much Fox News, but a lot of just different types of, bringing in different types of news sources so then that you're able to balance out what the truth is or the facts in the story. You have other bad things that are occurring with AI, which is basically criminals now. The ability to clone voices, to clone images. It's here, and it's very scary. You know, and you think about how individuals, how we use our social media to help show our lifestyle, right? You see people going on vacations. And looking at the audience, I'm sure that we've heard of stories of older adults that have been robbed of their savings because maybe it wasn't them that was posting their vacations, but it was their grandchild or a related person. You know, the video content that's being shared online and also the audio content, it's scary. And that's where what we believe is making sure that people are understanding the settings and knowing, you know, to protect your information from going public, but to exact a specific audience. And it could be used to what is that? It could perpetuate just information, stereotypes, or anything else. Going back into the manipulations of our beliefs and values. As we go, though on one end of the continuum, AI is great, and it's going to benefit us. But also at the same time, we must always keep in mind that it is something to where it could be used to fool us. Next slide. Is it doing it? Yeah, there you go. So when it comes into disinformation, and there's actually a lot of categories regarding that. You have disinformation and misinformation. Misinformation is sharing information that is not correct, but inadvertently. It's because you did not know. Disinformation is the sharing of information that you know is not true, but it's that you would use to manipulate. So in some of the, with some of the way that this comes to our lives every day would be catfishing. You know, catfishing is a common thing to where individuals would create a image or a profile which is not them. They steal the images of other individuals and their lives themselves in order to confuse or basically to fraud against other individuals. You also have propaganda. Propaganda is misinformation that's used, but yet it's to control our attitudes and our belief on a particular topic. Satire, parody, those are other ways where it's not truthful, but yet it's used to convey a point. With AI, now you have new types of mis and disinformation. One of them being is, of course, deepfakes. That is the ability to generate very powerful images and control not only what they look like, but also what they see in a very seamless and convincing way. With this technology as well, you have things called voice cloning, which is very alarming. This is the ability to record a small, maybe like a 30-second sample of a person's voice. But then with that, I mean, if we were to visually look at my voice, you'd see all these types of patterns going on. My intonations, my pauses. But with AI, it's able to do these very complicated activities to where it could actually use my voice, create it artificially, and I would have no control on what that would say or what the message would be. Next slide. So then with disinformation, AI-fueled tech tools make lives a lot easier, but sometimes there are consequences to that. If you think about a scenario to where there's voice calls, right? And there's an elected official who wants to convey the importance of going out to vote, or maybe a thunderstorm's coming by. AI is a great benefit in the way that that elected official could actually have his voice cloned. Not only in his voice being cloned, he could actually have it mimic Spanish, Mandarin Chinese, right? To convey that message across many different segments of his population or his constituents, I'm sorry. And then now on one way, that's awesome. That just shows a way to effectively convey a message to his population. But on the other side of it, it's kind of a misrepresentation to the individual. Because then here you speak Mandarin Chinese and you think that the person that you've elected is fluent in your language. These are these types of gray areas that we're right now running into with the use of technology. Another area with AI, scams, right? So you have the situation of who's had a tech scam? I would imagine everybody there, right? I just had one not too long ago, and it was about my toll road was late, right? And well, that's a big scam. Just think of how many people go ahead and you click on it. I had another scam as well, very innocent. It said, let's buy a dog. I was like, all right, we're gonna go buy a dog. I was all about that. So tempted to click, but if I were to click that, I knew that it was gonna connect me to an AI bot. An AI bot is a synthetic artificial intelligence little program, little machine that's going to give me the answers I want. Ultimately, it's going to lead me down something to where I'm going to have to divulge information against, myself, or the very fact that it sees me conveying this conversation about buying a dog. Social media, current affair. AI, I mean, there's a lot of disinformation. Even right now, there's some scary stuff that's going out, occurring right now. And then you just know all of those Twitter images, that not all, but there's going to be a percentage of those that are not correct, that they're manipulative and meant to harm and dissuade people from the truth. Essentially, AI online or anywhere online, that there's photos and videos, right? We've just got to make sure that we are relying on the appropriate resources that are trusted, and then also to make sure that we scrutinize and then we do our own research. If you look here, let me see if I can, will it zoom? No. Oh. If you were to look at that image right there, that is an AI-generated image. What typically I would do in this particular slide is that I would zoom in. This was during the Olympics in France, right? And there was a strike against the garbage men and all the sanitary folks there. It said that the trash was out of hand. But if you were to really look at that, you're like, wow, that is an amazing amount of trash. And then if you zoomed in, and I would zoom in on it, and you would see that every piece of trash is unique. It's no longer like a duplicated, where you crop and repeat, and you just do that to where you can see consistencies or patterns. With AI, you're able to create really unique, very believable, convincing images all the way down to the details. If we were to zoom in on Tom Cruise and then Paris Hilton, we would look to see hair. We would look to see wrinkles and just how people move around in a very convincing way. All right, next. All right, this one is a good one. Hold on. I'm going to try and, hold on. I'm going to try and share this. This is to showcase some of the features of AI. All right, I'm on Zoom. Allow. Share. Did it go on or no? Can you click the Visa, the Visa one, Visa one? All right, this is a very impressive type of technology that's out. It's through one image. Through one image, you can have and then you assert the audio clip. This synthesizes it and processes it. It's so amazing and it's seamless. Can you scroll further down? Go ahead and click on one of those. Go ahead and pause that, please. That's another just very impressive image. All of that was generated from one photo. If you notice the articulation, even how her pattern of speech pauses, you can almost, she kind of sounds like my cousin, right? To where I'm like, all right, that's a very believable image. Scroll down and go to that older gentleman to the right. I mean, once again, it really captures so much about a person, right? I just can't get over the seamlessness of it. Back in the early 2000s, I remember deep fakes were coming out, and you can kind of see it. You'd be able to see a little bit of pausing, a little bit of hesitation. Even the voices weren't right, but this stuff is getting more and more convincing. Go further down. Do that, the one in the middle. I mean, not only is it controlling the image, but also the perspective as if there was a camera and microphone there. You could put in the accent and everything else. I think when it comes into like art and a lot of creative industries, such as movies, it's very alarming. Raise your hand if you've seen the movie Flow. This is the one with the cat, right? Okay, there's at least one. It was nominated for an Oscar. Great movie about a cat, kind of like, what is that? The Life of Pi. It's a really deep, very meaningful movie, but it was done all on an AI platform. Typically, when you think about a movie and how and when it was made, there are probably hundreds of people, at least hundreds. Production, you have all these set crews. But with AI, there was an Academy-winning movie that only had 20 people, 50 at the most. And it came through such a convincing way of how it was able to tell an awesome story. Mona Lisa, right? Let's hear what the Mona Lisa, who's ever been curious about what the Mona Lisa sounded like or how she sounded like? All right, let's go ahead. Who knew she loved hip hop? Right? Isn't that kind of cool? It's just on one side of it, I'm amazed and I'm like, wow, I'm really looking forward to the future. But at the same time, I also realize how we need to educate more people on the uses of these tools and to always make sure that they're vigilant against a lot of that. I guess if we can go back to the presentation. Thank you. Yeah, I know I use a lot, at least I value AI and I use Gemini. And with some of the newer features like the Google Lens, and it's able to incorporate live video feeds into AI, which would mean I could take an image of an item or a video and it would help me identify or help me get some kind of information. I imagine like an EKG. I imagine there's so many practical applications of this that can help help us every day as we age. All right, let me see. Oh, there you go. So then with this particular slide, as we would see now, the VASA, which is a very high-end Microsoft type of pilot program, that was very smooth. There's a lot of work, a lot of value, or a lot of investment in those programs. But then also you have programs that are available for $5 a month to produce your own AI content, which is good. On those that are creative, we want to make sure that we're pushing that envelope, but at the same time, we have to be mindful that AI can easily fall in the hands of individuals. So then some of the best practices that we tell when we're looking at video, what we realize is that AI, it really doesn't know the physics or the physiology of the body, right? Because it's scanning all of these informations from the internet to produce an image. So one of the telltale signs of AI is that you would see people with no wrinkles, very clean, very polished type of looks. Some of the other things too would be those details, right? Wrinkles, hands, fingers. Sometimes I remember I did a prompt on the AI, which was a gentleman riding a bike, right? And then you went ahead and did it. But when I looked at the shifting, the integrated brake cluster and shifters with the cables, it looked real, but all of that was off. And the reason being is that AI understands the concept of a bicycle and a person, but now when you're putting it all together like an image does, it doesn't put all of the pieces in the right places. Unnatural facial expressions. Sometimes there will be like a tick. Sometimes there'll be just a few sequences that are off. Eyebrows. Those are some of the other things too. But now in saying that, I know who has time to validate every single image or every single characteristic of an image, right? And that's where I say, have your healthy sense of scrutiny, especially if you see something that's inflammatory to you, that makes you react on an image. I remember probably like 10 years back, I remember meeting an older adult who probably had $50,000 stolen from her because she received a phone call saying that a loved one was kidnapped. And I was like, wow, very convincing. It was very unfortunate. It was fraudulent. But can you imagine now to where when it's paired with an image or a video, it being synthetic, right? And that particular person, it wasn't her video. It was because of the younger generation posting all types of stuff and not using the privacy features of those apps. All right, next slide. Here, right now, there's a voice cloning, right? This is a gray area. There is no legislation that is set up to help curb voice cloning, but at the same time, if there's, from my research, is like you're able to sue somebody or have some kind of repercussion to those individuals if it's used in a nefarious type of situation. However, if you select to have your voice cloned under different types of applications, then it is legal to do that, which means it's available online for people to use. All right. 11 Labs, that's one of the more national leaders in, voice cloning. Yeah, that's about what I have here. Go ahead and next. All right. Going back to like best practice, it's really making sure that your sources are credible and reliable. making sure that you're familiar with sources. If you're coming across a link or something that you don't know where you received it on, first off, don't click on it, right? You'd be very hesitant to do that. And then if you happen to see images, just know, give yourself a pause. You know, you don't want to get into that emotional reaction. Verify your information. If you see something that you don't really know it's true, or if it is true, validate. Look through your more reputable resources. Some of them, like Snopes, is great. It scoops up all of the different types, or at least your more popular trending stories, and applies some bit of validation to it. However, the drawback is, and also with factcheck.org, is that they cannot review every single story. Right? It's going to do your most popular stories, or at least the stories that these agencies want to validate or confirm. Skeptical content often causes emotional reaction. Once again, if you feel yourself wanting to click, wanting to if it evokes an emotion or an action, sit back, have time, and then relax, and then to validate. Next slide. So then here are some different types of quizzes that you can do, you can practice on your own to kind of train your eye on AI. If you can do the second option, another quiz. Rolona, you're doing awesome. I know that I was supposed to do these slides. All right, scroll down. Yeah, there's a little bit of a firewall. Scroll down. All right, click to that right there. This is a little, who's participated in any of these AI quizzes where it's like, no, it's cool. It's available. They're free. This is images of who is that? There you go. We got Vladimir Putin there. And each one of these, and in my course, unfortunately, I don't have the ability, I would zoom in on every single one of those images. One of those images is AI. So if you look at the top left, right, what I would do is I would look at the lighting. I would look at the forehead, seeing if there's texture. I would look at the background lighting, and though the video here doesn't really capture it, but you would see light kind of shimmering off of his shoulders, right? And then also, if you look to the right, it's kind of a different perspective, maybe a different year. And then if you look at the bottom left, all right, you're like, wow, that's a kooky photo. Yeah, obviously that's AI. I can't imagine anyone doing that. And then you would have the bottom right as well, which is another one. This is more, you could definitely see the makeup more polished, more on a certain way. Who thinks the bottom left image of Putin is AI? No one. All right. Here, go ahead and click on the top right. I mean, yes, click that. And then that was the AI image. It was very convincing. Here it was a field of images with the individual, but yet you still couldn't do it. Here are some graphical, some artistic expressions of AI, right? Just by the look of it, who thinks the first one on the left is AI? No. First one on the right, it's a lot harder when it's actual art, an art medium that's being represented. There's one on the bottom left, and then one on the bottom right. And if you look at it, those are all very, of course, I'm not French, but if I was, this would have some kind of emotional connection with me. The one that's AI is the top left. Go ahead and click that. Okay, this is Chancellor Merkel. She's, one of these images are generated via or through AI, and it's her doing a lot of the first one on the left is her playing a video game. The other one is with her, ooh, what is that? She's watching, what is that, a tablet? Yeah, using some kind of device. The one on the bottom left is basically her observing a new type of technology that's being submerged underwater. And then another one is with her with a classroom, or I mean in an office space. Basically, the AI one is top left. The way that I saw that, it was her expression and if you look down, or at least if you saw her, her eyelids had a very particular way in all of the other images. Her wrinkles and her creases had some kind of thing. And in that particular image, I was not able to find it. I won't go too deep into this, but I will say is that one of these images are AI. And if you look, it's the individual crinkles of the paper. It's on there. This is going back to the shredding of votes. I don't know. I don't know which election it was. There seemed to be so many of them like that. But then you could see on how this could really evoke some kind of passion towards people on either side of it. Back to the presentation. Thank you. All right, I guess we're coming, maybe I'm gonna, are there any questions? Let's see, next slide. A lot of those, when you're looking at these tools, and there are tools out there to help you identify what AI is, I'm not telling you to go out and purchase these tools or anything else, but be aware they are available. They're not 100% correct or accurate all the time. And the reason being is that the technology is evolving. It's actually using AI now to help, improve its particular performance at images, manipulation, cloning, and everything else. Have you heard of scams or impersonate other scams, people or what people out of money? Of course, I'm very, yes, with this particular population. How do you stay up to date? Is there anybody in the audience that, how is it that folks, that y'all may stay up to date regarding scams? Is there a particular website? Is there a government website? Is it through conferences like this that where you learn about different types of things that are out there? All right. Regarding, or at least after this presentation, are who's more likely to use or experiment with AI? Yeah, more, few. All right. Well, that's the end of my presentation. Thank you. Oh wait, there are two questions in the back. Oh, one. Now you have AI filters that help take that out. And this is the thing, is that this lecture is probably maybe a year old, and yet you can see how quickly the technology has evolved. I mean, yeah, it's very convincing out there. All right. Any other questions? Yes, sir. That is a very interesting thing. The question is about how in this world that we live with AI, on which how different types of jobs are just changing. Whether, it's like, I remember the discussion regarding law, right? And then the understanding and research that's being done, that is for our elected officials to do. But in other ways that AI will disrupt our industries, and here, I look at aging. And I look at like AI, and I also look at robotics. And then the cost of home care is extremely expensive. But boy, would I pay, especially for any one of my loved ones, to have a robot essentially look after my loved one, being able to help them if they got out of bed, being able to have a lot of this Bluetooth and other types of seamless technologies connect directly to it, so then you would have a real-time reading on what's going on with them health-wise. I mean, this is where I talk about, this is a gray area, but this is the reality that we live in which AI, it's not going away. And it's going to be more and more prevalent, especially, and also robots as well. We already have automated robot cars in Austin, and I don't know if they're here in San Antonio, but they're just about. So to answer your question is going to be a real gray, I don't know. Yes, sir.
Yeah, when I was teaching, we have software to detect plagiarism. Is there any software to detect an AI-generated
Yes, on one of those, which is it? 11. uh, um, 11 labs. They actually had, yeah, 11 lab tools. It's used to detect the voice image, but also there was a writing prompt thing to where you could cut, paste, or load a document up. That with those particular features, there's going to be a pay option for them. But with some of these tools, they're free. They're free to use. All right. Any other question? Great. All right. Well, thank you.
Now that you've scared the hell out of us, thanks so much. I do have only one comment. Do you know, have you heard the Chat GPT in French? Anybody? Anybody speak French? How do you say Chat GPT in French? Actually, it's pronounced almost Chat GPT, which is exactly the way you say cat, I farted. Yes, Chat GPT. Yeah. So in fact, Jane's gone already, but Jane and I were working on something in a committee, and she ran it through Chat GPT, and I told her that story, and she said, well, then let's fart this out. So, all right, with that, it went to potty humor really fast. So we want to thank you guys so much. I think we're done. We want to make sure that you guys do the evaluations that were in your packets. And please turn those in. Folks online will be getting an online version of that, I believe. Is that correct? I think Lisa said, no. Is that right? Maybe for our folks online. And for anybody with CEUs, again, make sure you checked in. For our folks online. Your presence will count, and we'll send out those CEU certifications by email, probably within the next couple days, week at the most. All right, well, thank you guys. I don't.
Comes over so fast.
Yeah.
Put down resources.
Lisa, are we going to be able to send out a presentation? Yeah, so probably everyone's going to talk. Okay. Okay, I just heard there is no evaluation in your packets. Ha ha, gotcha. Thanks to those who paid attention. So we'll email those out.